Okay, so welcome everyone. Apologize for a little technical snafu today, but this is day 2 of our Integrative Reproductive Medicine Conference. Welcome to Yosan University. And we're very proud to have hosted these conferences for a number of years now, where we bring together the best of Eastern and Western medicine in the discussion and sharing practical protocols on how we can improve the outcome of a patient's fertility. Today, my topic is evidence-based Chinese medicine treatment of PCOS. And a little bit more background about our school. We are a nonprofit and also based on a Taoist lineage. Our current 2 specialty doctorates are fertility and healthy aging. We're in the process of preparing for our bridge doctorate program, which is pending. We'll let you know as soon as that is online. And we also offer, through our community partnership clinics, acupuncture and Chinese medical services in the community. That's entirely free. And we're also affiliated with College of Tao and Integra Health, our sister organization, which offers classes in all the Taoist arts, ranging from the I Ching, Qigong, meditation, nutrition, and Feng Shui. We offer retreats, both here in the US and in Europe. And we also certify instructors in all these Taoist arts and movements and energy healing. So anyone who might be interested, I invite you to look into collegeoftao.org. So today's topic, polycystic ovarian syndrome. In Western medicine is not yet fully understood, but it's understood as a complex and multifactorial condition because it also involves a combination of genetic, environmental, and hormonal factors. Here is a kind of a picture that is, I think, pretty good in demonstrating to you what a polycystic ovary looks like. Instead of a normal looking follicles, you have multiple cysts in the ovary. And of course, it creates a lot of problems. Let's examine how PCOS may lead to infertility. Obviously, it can cause ovulation problems where there's inconsistencies, irregularity, or no ovulation at all. You produce cysts instead of eggs. No question, it itself may cause or is the result of hormonal imbalance. There also may be structural abnormality, as you saw in that illustration earlier, and there may be an increased risk of miscarriage. Now, the common symptoms of PCOS, this is just common symptoms. What that means is that there may be other symptoms besides this. So irregular periods is oftentimes the first thing that patients will come in and complain about. And they may notice that they're breaking out, even at, into their 30s. Usually the acne or hormonal cause acne changes on the skin abate once a person is past puberty. But in this case, acne is still a big problem, especially the cystic kind. They may find themselves having excess body hair growth or hirsutism. They will also experience a weight gain in their body, more of a pear shape type of weight gain. They will also notice their head hair is thinning. There may be pigment on the skin. For sure, the driving reason for most people seeking treatment is they have difficulty getting pregnant. Besides that, there are mood changes and a number of other symptoms. So again, this is not a comprehensive list of symptoms, but rather just a common list of symptoms. Pain, of course, can be one of them. Pelvic pain, especially during ovulation and period, a very, very strong period cramping, and tiredness, as well as when we look at hormonal levels, they have high androgen levels. What are the causes of PCOS as far as we know it? Well, insulin resistance is a big cause. And I'll explain that in a moment, exactly what that is. And then we can check within the blood an elevated insulin and androgens, testosterone, for example. We'll also see chronic low-grade inflammation throughout the body. So CRP, C-reactive protein levels will elevate. Sometimes other indicators will also go up. And then there are genetic and epigenetic factors. For example, if you have a family history of PCOS, like your mother, then chances are you may also develop that sometime in your life. Many of the patients that I've seen actually develop PCOS very early on in their late teens. And so it's a kind of a condition that they've been dealing with. And in Western medicine, which our distinguished speakers after me will be discussing from a Western medical standpoint of view how to deal with PCOS, whereas my presentation today will be limited to traditional Chinese medicine's approach. And but birth control pill is oftentimes prescribed when someone has PCOS early on, in puberty, going through puberty in their late teens. And that, while that does control the cystic formations, it doesn't necessarily correct the problem. And so we'll take a look and examine some of the other things that we'll be doing in Chinese medicine to actually correct it. So we talked about insulin resistance, and this is a problem that is become very prevalent. We know insulin resistance can lead to diabetes, type 2 diabetes. And there are estimated approximately 30 million people that don't necessarily have PCOS, but have insulin resistance or prediabetes. So in the illustration to your left, you see a cell. And on this cell, there are insulin receptors. And then there's glucose ducts. So it's a really kind of like a Lego concept. So the insulin basically plugs into the insulin receptor. And what that does is in the illustration to the right, then the door opens. So whereas it was closed before, now the door opens and the glucose can enter the cells. In insulin resistance, that same insulin will go into the insulin receptor, but the door doesn't open, and therefore the glucose cannot get to the cells. And when that happens, the glucose will build up in the blood, which will then signal the body. And the net effect of that is that signaling process will tell the body, hey, we have too much glucose. Let's go ahead and store it up. So the liver will grab some of it and store it as glucagon, and the rest of it will be converted to fat. This is why there's weight gain. So here you are eating, and everything you eat, basically it's converted to fat, and your cells are still hungry, so it keeps sending signals to the brain. But the brain says, hey, I just sent you food an hour ago. The cells says back to the brain, hey, I didn't get that food, so please send some more. This is why in patients with PCOS, there's like strange cravings, and these people are hungry all the time. It's because there's a signaling problem, and the cells don't get the glucose they need. That's why also there's fatigue and there's other issues that happens. And of course, as this continues, it becomes full-blown diabetes, which will have many other complications down the road. But we're going to limit our presentation today to just PCOS. So the condition of PCOS can manifest differently each individual, and treatment should be tailored to each individual symptoms and needs. What I find really fascinating is that in our world today, everything is run by computers. The computer language is a binary language of 0 and 1. These are just bytes. And 0 and 1, the inventor of the binary language readily admits that he found his inspiration from the ancient Taoist philosophy of yin and yang, 0 and 1. And so the event of binary language gave us the digitalization of our world. So everything's run on computers, and you can imagine, right, the last few years with the supply chain issues and chip shortage, we've had some problems, running the world as efficiently as we liked. Now, the reason I'm saying this is that what 0-1 does is it produces a lot of data, a lot of bytes of data. So that all that bytes of data, what do we do with it? Well, we need to make sense of that data, right? Because data is just symptoms and symptoms in science. And so through a process of recognizing patterns, so the pattern recognition is a very important part of our technology revolution that we see around us today. And so going from that, all the bits and pieces of information, we recognize the various patterns, and then we put them into buckets that can be useful information. So we can establish cycles and trends and all of that. And the beauty of this is that the wisdom of the ancient Taoists and Chinese medicine, which evolved from Taoist philosophy, is precisely based on this model. So PCOS is well suited for TCM pattern differentiation and recognition, because you have all these symptoms and signs. Then we apply our professional differentiation because we recognize the patterns, and then we produce syndromes. Western medicine, which is still very analog, if you will, and not digital in terms of its way of approach, it's very much still in that analog process. And because PCOS is PCOS, and so there's one condition. In Chinese medicine, there is not just one PCOS. There is multiple syndromes that describe PCOS. So I find that the convergence of ancient philosophy and modern science and technology to be incredibly fascinating. And I've spent my life devoted to translational work between East and West, and between ancient and modern. How, what's old is new again, and how the laws of nature is the truism in which can be reproduced and seen in various patterns. And so we use the same kind of model to look at life events, weather patterns, disease, even predicting uh, epidemics and so forth. It's really fascinating. But anyway, back to PCOS. So in TCM, the pattern differentiation, we now produce 5 syndromes based on their unique set of symptoms and signs, right? So liver qi stagnation being one, dampness and phlegm, qi and blood stasis, spleen qi deficiency, or the new term for deficiency is vacuity. I'm kind of old school, so I still like the term deficiency, but I appreciate the new term of vacuity, which I know has been around for 20 some odd years. But the Chinese language is such that, you have several different ways to translate what the meaning of shu, which is deficiency or vacuity, or shi, which is excess. All right, let's move on. So the signs that you have liver qi stagnation includes abdominal pain and distension, mood changes and sleep disturbance, irregularity in women, headache, neck tension, and digestive issues like IBS, or what we used to call IBS. Let me share my screen again. I don't know why the thing stopped. So let me go ahead and pull my slides back. Here you go. Okay. Everybody see the slides? Are we good on the slides? Okay, very good. So I will continue. So this is, liver stagnation is probably the most common TCM syndrome, which applies to, by the way, multiple other disease conditions. And so we'll continue with that. The next one is phlegm damp, right? So phlegm damp deficiency, phlegm damp condition, which oftentimes is part of the spleen deficiency, but we will discuss that as a separate syndrome later. This is more of the excess dampness and phlegm. Now the difference, right? So we have to look at the patterns. This is different, but similar to the liver stagnation as well, right? So there's also the abdominal fullness and discomfort. But in addition, there might be phlegm, chest congestion, there might be fatigue, there might be joint pain, skin problems, and all of that. So in other words, just a few symptoms off. And of course, we confirm with the tongue and pulse. Tongue would be flabby, maybe thick white coating, or and the pulse would definitely be slippery. Whereas the liver stagnation, we differentiate it by symptomology, but also the tongue being a little dusky, and at the same time we have the pulse being wiry. So again, in pattern differentiation and recognition, a few symptoms off then becomes a whole new syndrome. And that's really the beauty of it, is that we can drill down and personalize each of these syndromes. And then there is blood stasis. And blood stasis is characterized by fixed stabbing pain, the pelvic area, swelling, edema, for example, painful periods, other gynecological symptoms. It also has digestive issues, emotional disturbance, skin change, insomnia. So you can see here a lot of similar symptomology, but now further differentiated is the pain is not just a discomfort or a bloating or a heaviness or a distension. No, now it's an actual pain, and it's stabbing pain, it's sharp pain, it's fixed. So it's always in that right lower quadrant or left lower quadrant pelvic area. And then it's accompanied by swelling. So again, and then, the dusky, like the purple tongue, the purple lips, the purple nails, and so forth. And the headache is no longer just a pressure, but a piercing headache. All right, the next syndrome is spleen deficiency. And now, besides, we saw the abdominal fullness and heaviness again, right? So these are all similar symptoms. We have digestive issues again. We have fatigue and edema, but now the patient presents not dusky, purplish, but pallor and weakness. They find themselves bruising easily, they have low appetite, and they may be suffering from prolapse of uterus, prolapse of bladder, and all that. So kidney insufficiency or vacuity. That's the fifth syndrome. Now, this is a little different. Now we're dealing with more, other type of symptomology than the first four we talked about. Because this one is more characterized by like irritability, heat flashes, lower back pain, knee pain, weakness in those areas, frequent urination, and maybe, a little slight leak, sexual dysfunction, including infertility. But of course, all the other four syndromes can lead to infertility, ringing, hair loss, low resistance to illness. Okay, so now let's examine treatment strategies. What we seek to do is restore balance and regulate menses, reduce ovarian cysts, and improve fertility, right? And besides acupuncture, of course, herbal, nutritional, lifestyle, qigong, stress reduction. And what I'm going to do today is to present actual evidence-based, meaning these are all based on studies, published studies. So these are protocols, as we know that one of the classic formulas in Chinese medicine for liver stagnation is Xiaoyaosan. And in a randomized controlled trial, Xiaoyaosan was found to improve menstrual regularity and the severity of PCOS symptoms. And these acupuncture points are commonly used. So there's nothing surprising to you, but what's really unique about it is that these are published studies that actually show that there are improvements. And then for dampness and phlegm, we can see the points are pretty classic, no surprise there. And Yiguanjian, again, another randomized controlled trial, found that this particular formula was effective in reducing testosterone levels and improving insulin resistance in women. Again, published studies that would basically back up the thousands of years of clinical experience. We know it works because we see the patients all the time in clinic, and they improve and they get pregnant. But until we actually can show with these controlled trials that there's a difference between the control group and the group that is taking the treatment, and we compare the difference between the two to show that there is a significant difference between the two groups. This will then be able to establish credibility. It's not enough that we can have patients give us testimonials. And they can do that all day long. But until studies are published, peer-reviewed, and acknowledged that it actually is true that we would have an uphill battle in terms of, convincing our Western medical colleagues to really take a look at what we have to offer. And through these studies, we're able to collaborate effectively. Qin blood stasis, 桂枝茯苓丸, and this was a meta-analysis of a bunch of studies. And this is probably one of the most studied formula, 桂枝茯苓丸. And it was found to improve menstrual frequency, ovulation, and clinical pregnancy rates in women with PCOS. Spleen qi vacuity, gui pi tang. Again, no surprise. There's a reason why classic formulas have lasted for thousands of years, and we're still using them today. Now, granted, you might have to modify a few ingredients, but that's okay. The basic formula still stands. And this one was found to improve menstrual cycle regularity and reduce polycystic ovaries in women with PCOS. Finally, kidney yin vacuity, and the classic formula study was 走归丸. And about 80 women were studied and randomized, assigned to receive that or the placebo for 3 months. And the 走归丸 group had significantly higher ovulation rates at 70% versus placebo group of 40%. And the 走归丸 group had significantly reduced levels of LH and testosterone. So again, really, really excellent. So besides acupuncture and herbal therapy, Qigong has also been found to be effective. Now, the beauty of Chinese medicine is that we use multiple modalities to help affect a change in a patient's pattern, presenting pattern. Chinese medicine is all about recognizing patterns of imbalance and then correcting that imbalance and restoring back to balance. And that's why no matter what disease it is, what symptoms patients present, it's almost in a way you can ignore the label of the disease and you just learn how to recognize patterns. Like AI, what AI is doing today with the algorithm is all pattern recognition. So back to Qigong. Qigong has been found effective for PCOS, especially a particular kind called the 8 treasures, which we teach at Yosan University as part of the Foundation Qi Development course. And specifically, 8 treasures Qigong was found in a randomized trial to be effective in improving menstrual regularity and reducing testosterone levels in women with PCOS. So again, it's not just, hey, do it because it's good for you, but do it because studies show that it actually helps. So now there's a bunch of other acupuncture research that, for PCOS that I like to just bring to your attention. So of course, a general statement can be made that acupuncture has been found to have a regulatory effect on the endocrine system, which may help explain its beneficial effects on PCOS symptoms. This is a protocol that was studied. So you have CV3, stomach 29, spleen 6, spleen 9, stomach 36, and LI4. It's a fairly classic acupuncture point combination. And, 30-minute treatment twice a week for 10 weeks. And the result of this particular study, but there's many other studies, this was published in the Journal of Neuroendocrinology, showed that acupuncture group had a significant reduction in testosterone level and an improvement in menstrual regularity compared to the control group. Now let's talk about nutrition. In the Yellow Emperor's classic Huangdi Neijing, nutrition has been considered as the first line of healing. And so at Yosan, we take it very seriously. We have an extensive nutritional curriculum, plus in collaboration with College Dow, we have a whole course that's a asynchronous course that you can take online that may lead to a certification in Chinese medical nutrition. So if you're interested, you can inquire. Dietary therapy. I'll give you an example because there's tons of other examples, but I'll just use an example of the glycemic index. In the Western medicine, glycemic index means foods that actually produce insulin response. It roughly corresponds to, in Chinese medicine, dampness and phlegm, because high glycemic foods generally have higher carbohydrates and sugar. And these, very specifically in Chinese medicine, tend to generate more dampness and mucus. And they include foods like ice cream, pastries, sweets, refined grains, milk products, and fruits. And then a low GI diet includes foods that are less likely to cause a rapid increase in insulin and blood sugar levels, which are basically, no surprise, vegetables, nuts and seeds, beans and legumes, fish, poultry, lean proteins. This is kind of a chart that shows the GI value. So it goes from basically 10, 20, 30, 40, 50, all the way to 100. And obviously you want to eat the ones that are lowest on the GI score, the glycemic index score. And another study published in Nutrient, in the journal Nutrients, found a low GI diet for 12 weeks improved insulin resistance, weight loss, and menstrual regularity in women with PCOS. So again, goes to show that diet does matter. What you eat does matter. Stress reduction. Chronic stress, no question, exacerbates insulin resistance because think about it. When you're stressed, you release cortisol. Cortisol is the same molecule as prednisone. When you take prednisone, you increase your blood sugar and gain weight. Voila. This is a very direct link, right? So obviously, meditation has been shown through studies to significantly improve insulin resistance and glycemic control. Here's a case study I'd like to end with. 39-year-old female diagnosed PCOS, plus she had fibromyalgia and infertility for 4 years. She underwent 3 failed IVF cycles. In Chinese medicine, I diagnosed her with dampness, but also B syndrome. She underwent 7 months treatment of weekly acupuncture, along with herbal, nutritional, qigong, and meditation practice. Her symptoms were she was overweight, irregular menstruation, distension, hair loss, ovulation pain, menstrual pain. She had cysts. She felt stiff, heavy, and painful in her muscles and joints. That's fibromyalgia. And she had sleep issues, and she was tired, prone to depression. Her A1C, which is a 3-month glucose number, was 6.2, which put her into the diabetes category. Her testosterone was 57, her E2 was 73, TSH, thyroid hormone was 3.8, and she was on metformin. She had a classic flabby, thick white, clappy tongue with thick white coating and slippery and wiry. Interestingly, this, in Western medicine, the thyroid number with the TSH would be considered normal. But really, if you drill down to it, the ideal range should be between 1 and 2. That's the sweet spot. So in this case, she also has low thyroid. But hey, in Chinese medicine, we just recognize the pattern as dampness and B syndrome. So of course, we want to transform and expel dampness and clear channel, remove stagnation, right? So these are the points we use. I use also E-stim at 2 hertz on all the painful joints. And then I prescribe the whole body infrared once a week, along with abdominal infrared 30 minutes daily. So I actually have her buy one of those heat lamps that we use in the clinic, and she used that at home for 30 minutes every day. And I used a formula called 活络消灵丹. 活络消灵丹 is interesting. It consists of these following herbs. And I'm not going to read each of these because you'll have the slides, but you can study as you can see, it's a lot of herbs that does exactly what we said in terms of treatment principle. But interestingly, this formula has been also studied extensively for PCOS. And this one study, a randomized controlled trial in 2016, found that this formula was effective in reducing testosterone levels and improving insulin sensitivity in women with PCOS. So while this formula was really more used for B syndrome, meaning arthritic and inflammatory fibromyalgia type of condition, it also had this property of lowering testosterone, improving insulin sensitivity. So fascinating. So I put her on a damp clearing detox diet. And so 24 ounces of veggie broth daily, along with mostly plant-based diet, and of whole grains, vegetables, beans, legumes, nuts, and seeds, and small fish and chicken. After 3-4 weeks, the diet was shifted to higher animal products, vegetables, beans, legumes, nuts, and seeds, without dairies, without much grain, sugar, fruits, alcohol, caffeine. Guess what? All those other things produce phlegm and dampness. Patient lost 11 pounds after the first month and subsequently lost additional 18 pounds for 29 pounds over 7 months. Interestingly, that was just a side benefit. And trust me, the patient was not unhappy. And after 7 months of treatment, her A1C dropped down to 5.7, which is normal now from 6.2. Testosterone was way lower at 22. And E2 estradiol went up to 151. TSH now is within the sweet spot of between 1 and 2. No longer any ovarian cysts. She went off metformins and she was taking NSAIDs regularly, and no longer because her pain went away. Her periods became regular and all the pain had abated. She got pregnant naturally at age 40, delivered a baby boy at 41. So in conclusion, TCM offers effective personalized treatment alone or in collaboration with allopathic medicine for the resolution and management of PCOS. So that is the end of my presentation. Thank you very much. So the question came in that from a TCM standpoint, if is cheese still not a good dietary choice because it produces dampness and phlegm? And the answer is yes. Think about this. Why we staying away from cow dairy? It's because it contains a lot of lactose. That's sugar. And so if you really want to have dairy, I would suggest that you switch to goat or sheep. So the studies on Iguanjin is a 3-month study. So you should definitely always ask patients to stay on the protocol for at least 3 months, if not longer. So, okay, so another question came in. Clinical patients present with multiple symptoms, 2 or 3 patterns at the same time. Yes, due to formula modification for each of those. Give me an example. Okay, so yes, in TCM, sometimes we have patient who maybe share a multiple syndrome. Again, we're trying to figure out what the pattern is, right? And so sometimes we see that, okay, it's not just a let's say spleen Qi deficiency, but it also has spleen Qi deficiency and excess dampness and phlegm. And so in those cases, for example, you would definitely have to modify. You can't just use Gui Bi Tang, for example, even though it's classic, it's prescribed for that. You really need to also incorporate dampness transforming herbs. And spleen tonics in general are not as greasy as blood tonics. So luckily that's not an issue, but you can definitely combine 2 formulas, right? And then differentiate from there. And so also a question came in that, hirsutism, where there's excess hair, and where does that fall into in TCM pattern? So in those cases, we often see that more often than not, that's either a blood stasis, Qi blood stasis, that causes the hirsu, or we also see indeficiency, like kidney indeficiency. So there's the heat. So it's a symptom of heat. It could be excess heat, could be deficiency, but in the terms of um, in terms of the manifestation, you have to look at the other symptoms. So this is where, again, very important to differentiate. If you were AI, artificial intelligence, you would have been trained to recognize very precisely certain number of symptoms that come together or combine together, right? So that's why you need to really be very, very precise in your differentiation. So another question, patients high cholesterol may not be able to eat seeds of certain type, vegetables, dairy, do you have any dietary recommendation? By the way, nuts and seeds do not contain cholesterol, and in general, the fat that they contain contribute to good cholesterol. So you don't have to avoid nuts and seeds if you have high cholesterol. However, having said that, you, of course, if you have high cholesterol and you want to lower that, you want to go with a more plant-based diet, and you want to cut out dairy products, because dairy as an animal product do contain saturated fats and cholesterol. So that's where you're getting a lot of the cholesterol. Oh, and I guess one last question, do I prescribe supplements as inositol, NAC, alpha lipoic acid? The answer is yes. In our doctorate program, I teach a class on translational nutrition, which is translating supplements into TCM actions and how to use them to treat so that it fits into the framework of TCM. So instead of being haphazard and then a little schizophrenic, switching between Western nutrition and Chinese medicine, I put together all the supplements and with their TCM action like you would find in an herb, for example. And so that's how you can practice TCM.
Right. So then it would be PCOS, not endometriosis.
Correct, because he was dealing with stress, and PCOS is dealing with hyperactive.
So we'll start in about 10 more minutes. I just want to point out on the screen right now, Yosan University is starting a community and group acupuncture clinic Wednesdays from 4 to 8 p.m. This will be managed and staffed with doctoral students. It's donation and sliding scale fees, so please send your patients who are looking for more acupuncture. If you have students or other friends and family members who are finding acupuncture to be a bit too expensive, I would highly recommend they come to this acupuncture clinic. If this goes well, this is kind of a beta test. We intend to actually run it twice a week on Wednesdays and Saturdays. And Saturdays, if we can get that running, we'll also have Qigong and meditation classes attached to it as well. So once again, group acupuncture clinic, community acupuncture clinic starting Wednesday, March 22nd from 4 p.m. to 8 p.m. Thank you. I'll do it right before you come.
Test check 1 2, test check 1 2, test check. Test check 1 2, test check 1 2, test check.
You can ask me anything. You pay for the course. I'm not an active consultant. No, but he is. He's an active consultant. I think I'm honorary doctor. It can manage hernias.
Question. I don't know because I know it's a little bit of
Robert, does an acupuncture treat hernias? Her father has a hernia.
to reduce pain.
Okay, it's, yeah, it's a surgical. It's a surgical.
Yeah, that's something I have to recover surgery.
Are you a student?
Acupuncturists will always say that if you get it, it's don't do it. So the question always to ask is, have you ever done it clinically?
And see it work.
And see it work. Always ask that. Have you, because they'll say yes, it can. Can acupuncture manipulate your car? Then ask them, have you ever done it for somebody? Always ask. Theoretically, you can do almost everything, but see if they have the skills to know what to do.
Feel
So
chilled.
I would say, a lot of things in surgery like that.
I mean, his health is already kind of, so I think I can help him.
My flight was delayed a bit, so I'm gonna sit for 15 minutes.
I love it.
You saw, I put your shirt here too.
Oh, yeah, I'll put that in the thing here.
I'll send you your fee later.
Okay. Hurry up and wait. Family okay? Don't know, didn't see him last night again? Asleep? Yeah, did you?
Saw my wife.
Yeah. Kids doing okay?
Yeah.
Yeah?
Nobody's dying.
That's still there.
We're still crying.
They're still crying. Many layers of life. The onion of life. You peel it away. Yeah. Yeah. I can tell you from my standpoint, there's a confluence of East and West that's now almost irrefutable. It's just, it is the one medicine that I've always believed in. And it's because you're dealing with an organism, and it's the same one. I don't care what you call it, French, German, you can call this anything you want, still, it's a buttocks holder. It's a buttocks holder.
We were having like a pretty big discussion at the ACOM meetings last week, because, this entry-level doctor, like, the only thing we could come up with that was universally useful was talking about
Because they wanted to be short. Rather than integrative, collaborative.
Or no, integrated, collaborative, yeah. And so now, we're creating those programs, we're saying the BAOM is not integrated, we do that. And I'm like, no, you don't. Just because you teach a couple classes about what integrative looks like, you're not teaching collaborative. You're teaching about
What is this bridge
it's away
from the master's level without going through the doctoral program?
1 year program.
Okay.
Online classes.
Got it.
What is research 101?
Got it.
Integrated
Yes.
care models.
Okay.
So that we're
So value
entry level practitioner, same level.
Yes.
Right, because they were all
PTs and
PTs and chiropractors. They're all graduating now.
Right, and also the nurse practitioners are doing the same thing.
So it's just that level. They're trying to say that you're not in
No, you're not. You're wrong. Yeah, you're simply not doing it. Yeah, even this is a good jump in the pool, but it's not up to it.
But we're not going to see that graduate to the entry level doctor.
No, that's a disservice to the patient, because now you have a title which they without the depth.
What's our
So,
Been there, done that.
yeah, I mean, it's like having a baby without the faster. It was something like that, natural thing, that the law has allowed us to teach about, so we should just get it assessed by it, yeah. Where do you live?
Could be an orthopedic surgeon.
Yeah, is that what, yeah, I was just telling her, so it's well, so if he has a
It's reproductive endocrinologist and a special project, a team leader, director of special projects. That's scientific, Emperor.
Emperor, sovereign? All right, should we come on back? Welcome back. We now have local control. Dr. Mao is observing from wherever he is right now. So for the people on Zoom, you have missed an incredible morning here. We were learning astral projection, levitation. We cloned Lauren Brown. He's now in 3 places at once. And everyone has a special gift here that you can only get on campus. So just saying, you didn't miss much, but it's okay. Your chat and question and answer online should be back to its normal function. We didn't want to disrupt Dr. Mao's presentation while he was on there. So log your questions in there and we'll get to them at the end of each speaker. Is Farshid in here? I'd want to send a special thank you out to Dr. Namin. He's not here, which is because he's running around. Yosan has been through a lot of changes in the last year, and we cannot put events on like this, and really can't run the school without our incredible staff. And Dr. Namin has been our right-hand person. He's been very quiet, like over the last few years. You don't even know everything that he's doing, but in the last year, we elevated him to the director of clinic and dean of research, and he's stepped into that role incredibly. And I do want to take a moment to introduce Anissa Kasim, who's our new master's dean. She's also helping us with this event and will be tasked greatly. She's like, I have so many ideas. And I'm like, oh, careful what you wish for. So we're really happy to kind of be restructuring here. And we've got an incredible team. And of course, Tora is here just diligently, quietly, always doing the things that she does. So we're very happy to have her as well. And of course, our student volunteers. Again, it would be just me, Farshid, and Anissa late at night and early in the morning trying to get all this done if it wasn't for you guys. So I'm very appreciative that you're here. Let's move to this guy. He's the #1 budget buster in the history of Western medicine and Chinese medicine, but it's worth it because he's amazing. Dr. Paul Magarelli, as I've mentioned, you saw him all day yesterday. He's the co-chair of our reproductive medicine doctoral specialty. He's now doing research advisement with our doctoral students. He teaches actually in both programs. He teaches metabolic syndromes in the healthy aging specialty, and also 4 different classes or 4 different tracks of classes in the reproductive medicine specialty. He is the king of all projects, director of projects at KindBody, also practicing as a reproductive endocrinologist. He is a co-creator of ABORM, a co-creator of our doctoral program, a specialist in Mexican shrimp reproduction, and the husband of Diane Credenda.
That's the one.
So, Dr. Paul Magarelli.
Thank you, Senor Roberto. Thank you. I want to remind everybody right now, March 2nd and 3rd, 2024, we're going to be here again doing this. So put it on your calendar now, tell all your friends, relatives, etc. Because I don't know how you feel about what's been going on these past 30 hours, but for me, it's been a remarkable testament to the evolution of truly integrative reproductive medicine. And that's kind of been our main discussion, but we could talk about a variety of other disorders and diseases. I've listed on the board here, I don't know if the people in the intranet can see that, but basically yesterday we talked about endometriosis, we talked about ovarian hyperstimulation. This morning we're talking about PCOS. Thematically, it went from disease to syndrome to differentiation of syndromes. Things like, or issues like fertility, fibroids, autoimmune disease, obesity, diabetes, cardiovascular disease. Oh my goodness, there's a theme here. And everyone is reflecting back to oxidative stress and inflammation. And if you haven't heard the term or you don't understand what insulin resistance is, I thought Dr. Mao's very succinct picture of insulin resistance was wonderful. It's a switch, which is purpose is to provide energy to the cell. And if you can't get it in, The body is going to do everything possible to either store that energy for later, we call that fat, or it's going to just run havoc on your system to deal with the sugars, and think of them as glass in the bloodstream. It's going to try to manage that. On the right, if you haven't gotten the theme, what we need to do now is not medications. It's looking at the person, looking at the effects of the environment or the epigenome. It's to look at how you, the individual, can create your own life within yourself through diet, lifestyle changes, appropriate uses of food, energy, rest, mindfulness, qigong. I mean, this is the thing that you do, and this is the power of your medicine. That's what I'm hoping you bring. With that being said, because I had a little more time here to say that, I'd like to talk about the Western perspective on polycystic ovarian syndrome. The point of this slide is, if you quickly read it, it says PCOS is multifaceted. It's heterogeneous, which means it's really hard to figure it out. And as Dr. Mao explained, Western medicine calls it PCOS, and you have at least 5, if not more, differentiation of syndromes, which I'll address a little bit towards the end, that you can look at the patients with a like a Drosophila fly's eye and see all the different facets that are combination. It's also a diagnosis of exclusion. Sometimes we as Western docs have to figure out it's not a tumor. It's not simply a metabolic disorder. It's not, something that has happened because of some genetic predilection. We don't know what it is. And anytime in medicine you hear the word syndrome, in your mind say, they don't know what it is. That's really, please do that. And I'll talk a little bit about the difference between diseases and syndromes, but in your mind think, okay, they're not adequate, their medicine, which is only 500 years old. I mean, give us a break. We're like, toddlers compared to your medicine in terms of the observational component of looking at human beings. I was talking to Robert a second ago, and I said, what really ties us together, we're looking at one organism, the human being. Whether it's Chinese medicine, Ayurvedic medicine, Western medicine, Eastern, we're looking at the human being through observation, palpation, in our case, lots of tests and measurements. So why doesn't it come to confluence? I think Dr. Belsos was saying, dovetails. Why wouldn't it make sense that we can now tie observations? And I'm going to show you those observations, especially in this area. I found this image. It was a logo to the first clinic I set up for the management of PCOS. This is 20 years ago, which blows my mind. I as you can see, and we talked about the ovary having cysts. So I made the treatment modalities. I just love this. It's kind of cute, I think. That's the way I looked at this 20 years ago. It started as the Advanced PCOS Institute for managing fertility patients who wanted to get pregnant, but kind of didn't want to go to IVF. At that time, IVF started at about $25,000. And so they just needed some alternatives. So we looked at medications, of course, but we also looked at the diet, the proactive things we can do in terms of disease prevention. We looked at habits, in other words, now you're talking about lifestyle. We looked at community. We didn't talk a lot about, I guess we haven't talked a lot about in these lectures, the need for community. There are endometriosis societies. There are PCOS societies, communities online that you can send your patients to for support. We have a whole resolve.org, which is an organization for infertility. We have all of these tools, and then we have us as a community. One of the big values, someone asked me, is it worthwhile for me to take the exam for ABORM? I said, you know why it's worthwhile for you to take the exam for ABORM? Is once you pass, you are now part of a community of almost 1,000 acupuncturists who are board certified, who are focused on fertility and other aspects that are going to help you
I always moderate is not the right word. I'm always following the ABORM Google group, and you have to be ABORM certified to be in it, but they will help you on any patient, anywhere, anytime. So community will help endometriosis, they'll help. One of the key things, even in infertility, is if you know someone who's had ovarian hyperstimulation, as Dr. Diane talked about yesterday, it's the greatest thing to talk to somebody who's been through it, because it's scary as hell. And then, of course, Western medicine and traditional Chinese medicine. Oops, go back. You can read that, but I am not a TCM practitioner, nor do I play one on TV. So don't ask me about, Shen disturbance. I may have it, but don't ask me about it, okay? Okay, because I just don't know. Very simply, what is PCOS? How do we diagnose it? Now, Dr. Mao did a fantastic job, and I will cut past, not to be repetitive, just so that leave more time for questions, but I will cut past a lot of the things that he included. And I think Peter, you found this yesterday when Dr. Mao talked about endometriosis, and you did. He said, "Oh my God, he said that." That's great. Do not see that as a fault of this program. See it as a confluence that when we're talking about Western and Eastern, even though I'm tasked with the Western, I'm going to talk about Eastern. And even though someone else is talking about Eastern, they have to talk about Western because it makes sense when it's brought together. It makes sense when it's brought together. That's the key. And I think that's the juice of all of this. I mean, that's the thing where you should walk away going, oh my God, if I can collaborate, cooperate with my colleagues as well as my reproductive endocrinologist colleagues, that synergy is what's going to bring your patient to health and wellness. I mean, that's why we're doing this. There's been about a 65% increase in the prevalence of PCOS. And by the time this is over, you're going to go, oh, that makes sense. But I want you to keep that in the back of your mind. Over the past 10 years, PCOS symptomatology, the signs for PCOS, the observations of ultrasounds on the ovary to see the PCOS-like ovaries is like increasing almost way more in the female population than the pandemic did. So it is something epidemic-like. All right. Who knows what PCOS is? Please raise your hand. Good. So you have a lot to learn because I don't know what it is. Okay. I mean, then I want whoever raised their hand the highest, the podium is yours. I have asked this question since 20 years ago, and the bottom line is the reason I don't, in Western medicine way of thinking, I'm assuming you were answering the question in a Western medicine because you don't have PCOS. Those terminologies you don't have. You use them, but you don't have PCOS. You have stagnations, you have the acuity, you have these things, but you know. So when I say syndrome, it means we don't know. So just remember that. So what I put up here is sort of I was kind of, how do I visualize for you what I'm going to talk about today? Well, there it is. PCOS, insulin resistance, the Western medicine view, how it correlates to traditional Chinese medicine, the traditional Chinese medicine view and how it correlates to Western medicine, and then finally, how do we approach this in sort of that dovetail combination. Then this is my slide, which was going to be at the end, but I decided to bring it to the beginning so you know the conclusion, is that we love names in Western medicine. Probably you do too, but I don't know. But Stein-Leventhal syndrome is what was originally described for this odd acne, hirsutism, inability to get pregnant, irregular ovulation in the form of irregular menses. Then we went to surgery and we saw these kind of weird looking, dense ovaries with lots of little cysts in them. And so they said, oh, it must be a disease. So they called it polycystic ovarian disease. Well, when you have a prevalence of greater than 15% in all females, and now that has multiplied by 65% going forward, it can't be a disease because it has to be a characteristic of the human. It's not a disease when it's a characteristic of the human. You don't get 35% of people with a disease. born that way. You just don't. So we changed it to syndrome because we didn't understand it. This is the take-home message, and it'll help you understand when we talk about PCOS, and that is there are two major components to it. There's a reproductive tract component, and then there's a metabolic. They could be both. This will get rid of a lot of the confusion you have in the studies that you read about PCOS, because each of the observers or the scientists looking at it are dealing with an aspect. So if you go down the reproductive tract, we go X, Y, and Z. If you go down the metabolic tract, it's A, B, and C. It still has a derivative from the PCOS type syndrome, but when we start describing things, the confusion will go away, meaning oh, now I understand why, for example, I hear this. My patient, TCM practitioner, I treated her. Dr. Mao gave a beautiful example of a patient. He treated her holistically, and she was able to ovulate. She was able to procreate. She also lost 18 pounds, and every study I've done and seen says if you can lose 10% or 5% of your body weight, you'll ovulate and get pregnant. Was it the Qigong? Was it the herbs? Was it she lost 18 pounds. Is it that simple? And then you'll see studies that say, for example, he showed some studies from traditional Chinese medicine practitioners' studies saying, we made PCOS ovaries disappear. Wow, that's we made you shorter, or we made your eyes blue. To me, that's the translation. But that doesn't make sense. But it does if we can separate out the characteristics, which I will today. You will have a way of looking at PCOS today where you can definitively say, this is where my patient is at. We've never had that. And you're going to see it's 2023. That's what I put on there, 2023. So there are a lot of things that can take a normal phenotype and make it look exactly like a PCOS phenotype, the way the body looks, observes. Not a genotype, which is the genetic basis, but a phenotype. So, if I can take this to here, is it this? Or is it this? And then, as you see over there, I talk about metabolic syndrome and insulin resistance as being the root to a lot of the issues associated with the diseases that you're going to be managing, both fertility and non-fertility. And guess what that says? That's variable too, because you can impact that with lifestyle, diet, and a variety of other things. So it's a very dynamic soup of things that we use to describe PCOS. This was a postgraduate course, 2010. I refused to make other slides, just copying it because I want to give them the credit for it. But it was fantastic, and I still think it's fantastic to get an image of what we understand, certainly the phenotype of PCOS is. So androgens are testosterone, right? Androgens are hormones that have testosterone-like effects, DHEA, DHEAS. These have androgen-like properties. So in patients with PCOS, they have hyperandrogenism. And you'll understand that at the end of this lecture. Why? It congregates around families. So there is a genetic component. Now, here's the weird thing about a genetic component. Historically, Mendelian genetics was simply the chromosomes did this and that's what happened. With epigenetics, 99.9% of every single one of you are exactly the same genes, in the same order, in the same place, but what changes is by your environment and your diet and your culture and the location where you grew up and your exposures, toxic or not, turns on and off through epi on top of genetic ways, the things that you see expressed in the phenotype. So doesn't it make sense that there are family aggregations that appear genetic? They're not necessarily that there's a break in the gene, but I grew up as Italian, pasta, cheese. And as my lovely wife is always willing to tell me, I'm allergic to both. And I have a sensitivity to both. But culturally, that's like telling me not to live. Don't breathe. You know, you can't have pasta and you can't have cheese. It's like, what the hell am I living for, right? I mean, there's no reason to live. So in my family, obesity, diabetes, I am PCOS male. I'm proud to say it. You know, I have insulin resistance. But of course it runs in my family because we ate the certain way. We're from the same part of Italy. It's just, these are things are aggregates. So don't get, when you see the words running in families as genetic, think also epigenetic, which may be change the culture, you change the individual. One of the things you heard was transgenerational impact. And I'm going to show you a beautiful slide of that. By the way, this lecture is like 2 hours, right? Where's Robert? Right? Good, because I got the podium. All right, let's move on. Okay, so you know what? Hirsutism, too much hair, acne. You know, you all know what acne is. And although they're showing you the criteria in 2010 based on the Rotterdam consensus, I'm going to show you that because it's a syndrome, a bunch of experts have redefined what the syndrome is and what makes up the syndrome. Ignore it because I'm going to give you the 2023 stuff. Read the literature. Don't get confused. They just didn't know, or it's evolving. But Rotterdam was when they said, okay, if you had hyperandrogenism, if you had anovulation, if you had polycystic morphology on the ultrasound, you have PCOS. Well, you're going to find out yes and no. Not everybody looks that way. So this is the beautiful picture of an ovary with what we call the string of pearls. In other words, under the cortex of the ovary, you have these beautiful cysts, and it looks like a beautiful pearl necklace. So the string of pearls sign is how we say, okay, this is a polycystic ovarian appearing ovary, and they're usually anywhere from 2 to 8 millimeters, and that's critical. And I'll show you why. Now here's where again, an important slide to understand what we don't know. Nothing on this list is 100%. Nothing. So hirsutism, oligomenorrhea, infertility, polycystic appearing ovaries, obesity, amenorrhea, acne, dysfunctional uterine bleeding, normal menstrual pattern, virilization, which is androgenism taken to the extreme. But nothing is 100. Therefore, not a disease, right? Diseases are 100. You have this, that makes it a disease. It's defined. You don't have this. What is it? It's a continuum of symptoms and signs that you can use to channel the patient to those changes, regardless of the diagnosis. What bothers a lot of folks, and I've learned this now, you don't need to test to do a lot of things. You just observe. When a patient says they're infertile, what am I going to test? You had sex, it didn't work. Let's figure it out. Let's just do something to make it work. There's not a lot of testing that's going to confirm that they're infertile other than a baby. So why don't we just get them a baby? Who cares the reason, right? Now, maybe you don't feel good about that, but as I get older, that makes more sense to me. PCOS, well, how could you say they have insulin resistance? Are they over 25? Do they have a little meat, a fat around the belly? You got insulin resistance if you're in America. It's almost that simple. So you can manage what you see. And here's the weirdest thing. When you take internists and you take gynecologists, reproductive endocrinologists, and you ask them what tests we should do, you can see that there's different vision on the side of the internist on what's important and the gynecologist. An obvious example is the internist, hell, they don't know what the hell an ultrasound is. They won't even touch a vaginal ultrasound, whereas a gynecologist, that's what they do all the time. So they use that as a diagnostic tool. 91% of the doctors will say, yes, do an ultrasound, you can tell them what they have. Whereas the internist is looking for a diagnosis of exclusion, which means they're looking at other things like congenital adrenal hyperplasia, a problem in the enzyme pathways. So they're going to do 17-hydroxyprogesterone and DHEAS because they're endocrinologists looking at the adrenal glands. So the literature that you're going to be, as you research this topic, if you're interested, you have to understand who is doing the asking. In other words, what kind of a doctor is asking? And even gynecologists are different than reproductive endocrinologists. I thought that was interesting. You'll hear me use the word metabolic syndrome, insulin resistance, insulin resistance. You'll hear me talk about syndrome excess. It's a problem with how you manage sugars. And it's a problem with how your pancreas secretes secretory pattern for insulin. And it's a problem of exposure. That's what it is. But guess what? The grandfather of PCOS prevalence today, that's being causative in this, in what you're seeing, is excess access to sugars with not a mechanism by which you can manage them safely in the body for survival. If I get time at the end, which I hope I do, I can ask you, you can ask me questions about that. Why is it important? Because in PCOS, insulin resistance is rampant. I mean, it's 70% of women who have PCOS will have insulin resistance. And here's the hard part, and you'll see why. You have the lean controls is showing insulin sensitivity, which is the converse or reciprocal of insulin resistance, right? So the more sensitive you are, the better. That means your right amount of sugars in your blood and everything works, to a low amount of insulin sensitivity. So if you're obese, that changes it. You can have none of the other patterns that are PCOS. But if you're a lean PCOS, BMI of maybe 19 to 25, you may not even have acne, but you do have some irregular periods, hard to see, your insulin sensitivity is less. And then if you're obese on top of having the genetic or epigenetic predilection for PCOS, now your insulin sensitivity is falling to the ground. Think of it conversely, now your insulin resistance is going up. So the language of PCOS today is insulin resistance. That's the language of it. The fundamentals of it will go through, but that's the language of it. This is everybody shows this slide of Aphrodite, this, a caveman's image of the most fertile woman. You'll see this in all the fertility lectures. This is what our cave people decided is what the little icon they'll carry around to get babies, right? That's the mythology around this, right? When you hear metabolic syndrome, when you hear insulin resistance, when you hear syndrome excess, think, what kills my patients? Seems dramatic, but it's what kills my patients. Heart disease, cancer, cardiovascular disease, and diabetes is a big, more than 50% chunk of what's going to kill your women. Cardiologists have known this for years. It is the #1 killer, not breast cancer, although that's a much more political disease. It's not, it's cardiovascular disease, heart attack, stroke. It's atherosclerosis, hardening of the arteries. It's diabetes, obesity. So if we're worried about PCOS from a fertility standpoint, think more generational and say, we're worried about it for your health and wellness for the rest of your life, as well as your children, great-children's children, which are grandchildren, and great-grandchildren. Because we now know that a insulin-resistant pregnant woman carrying a female infant will have a baby who has insulin resistance and PCOS-like characteristics, will have a baby girl with insulin resistance, even if they fixed it, meaning that second generation kind of did lifestyle, acupuncture, all these great things, still the propensity for insulin resistance and PCOS-like syndrome comes up in generations. So it's a transgenerational disease, and that makes sense. It's epigenetic. We change things. We change how things turn on. That's what happens. That's just a person who's carrying sticks, not of dynamite, but sticks of butter. That's the imagery around the impact of fat, right, of obesity. I'm not going to spend any time on this. There's a lot of extra slides. I can't help it. It's just the way I am in your syllabus that I'm not going to cover, but you're going to cover when you have the time to look at. I did talk about the various different categories of insulin sensitivity, but this is an image of a patient who has what they call android obesity. And oh my God, this is 1960. This is, 10,000 years BC. Nothing has changed. Humans are humans are humans. They respond in a certain environment. I just was like, oh my God, isn't that cool? I mean, that's just cool. All right, I'm not going to go over this one again. You had plenty of time to review that. I'm throwing this out here called Syndrome XS or XX because they thought it was a female thing. Please ignore that. There are many PCOS-like males out there, which is basically males with severe insulin resistance and infertility. I'm going to do an aside. We don't have time, but your reproductive endocrinologist will tell you, a woman, oh my gosh, ma'am, you have to lose 50 pounds before we're going to send you for IVF treatments because it's going to help you so much. Well, okay. How much does it help me, doctor? You have a 14% chance of having fewer children than if you were treated as an obese woman. Wait a second. You just said, yes, per transfer, your pregnancy rate go up. Per life, you'll have 2 or 3 fewer children if you wait the year to lose that 50 pounds if you do it. Tragic. They forgot the male. If the male has any form of obesity, and that's like a BMI of 30, 40% reduction in pregnancy rates in that couple. It's never spoken of. Whisper, whisper, right? That's a dramatic. Now, it says if you're not obese or you're not have insulin resistance, you're better. But it also says don't delay getting pregnant because, as we know, our fertility for females has a time clock. So I showed you this slide because I like it. And just to give you an idea, a multicystic ovary on the left is not a polycystic ovary, which you see on the right because of the size of the follicles. And there's that string of pearls again. So this is the slide that I wanted to sort of mimic from Dr. Dow's description of the lifespan of a disease. And then I'm going to take this slide. I've got to 11:30, right, Robert? If you look at the lifespan, a female in utero, adrenarche, that's when hair starts to show, puberty, adolescence, adulthood, pregnancy, back to a female in the uterus. I just put in the yin yang symbol just to say, and you can put a lot more on here. This is a Western medicine view of the PCOS lifeline, right? The changes that are required, the epigenetic changes, inflammatory factors, how the environment impacts it, how exercise and activity, hormonal exposure, whether voluntary or involuntary, like xenohormones. Fat itself is a hormonally active organ. It is not this passive thing that insulates. We didn't spend a lot of time on it, but the cytokines and factors that are going on in the soup, especially intestinal fat around the intestines, that's remarkably metabolically active. Ovarian factors, the excess androgens, how they impact it. Insulin itself is perceived by the ovary as IGF, and the reason it's named IGF, which is a factor for things to grow, it's insulin-like growth factor. That turns on androgen production. So if you have excess insulin, hyperinsulinemia, you have the ovaries going, oh, you want me to make more androgens. And I'll show you what that does. So where in this process, remember I said remember the size of the follicle, where in this process do PCOS patients' follicles stop growing to create that beautiful string of pearls? Right there between the primary and secondary follicle. So you have this lifespan of a follicle which contains the egg. Think of it as an egg house. You have this lifespan of growing things, these beautiful follicles containing eggs, and for whatever reason, and we don't know the reason, it stops right there. What's interesting about this, and I think you especially you seasoned folks who've spent 10 years in this industry, look where it stops. It stops when the follicle starts secreting AMH, when the androgen receptors are now getting proliferating within the ovary. So what do you see with PCOS patients? Elevated AMH, because they're stuck here. Notice the AMH stops secreting once you get to almost the point of and I know some of you are going like, what the hell is this guy doing? But you folks who work in IVF, this makes sense. This tells you why your PCOS patient will have elevated AMH. This tells you why your PCOS patients are so secretory for androgens. It tells you right there in one slide. And so you never have to remember anything if you understand the physiology. That's the thing that I've learned. Once you understand the physiology, nothing to remember. There's no memorization. So I was like, holy moly, isn't that simple? That's what it's doing. So on the right, you see an abnormal ovary. Dr. Mao's picture was better than mine. And on the left, you see a normal ovary. But the point of it, the only point of it here is that everything else is similar. Nothing else is broken. Uterus is the same. Fallopian tubes are the same. Ligaments are the same. It's just something physiologic is happening here. It expresses itself as a dense, hard ovary because the ovary is made of two parts. Think of the ovary as a peach. The meat of the peach, the stroma, is where the hormone factory is. The skin of the peach is where all the eggs hang out. So if you're stuck in being receptive to androgens and later on, insulin resistance is causing you to produce more androgens or hormones, and you have a turgid, strong capsule, the skin, it gets bigger and bigger, but gets denser and denser because it's under pressure. It only can go so far. So that's what we see. And I asked Diane this question, and I'm not going to have you guys answer it, but in traditional Chinese medicine, do you have something that says biologic function stops at a certain stage of development? Do you have some Chinese word, some Chinese syndrome, something where you go, this explains a stoppage? That would be right, stagnation, right? Right. It is not doing its process of, you know, the cycle of life. It's not doing its life cycle. Dr. Mao did a fantastic job. I'm not going to spend any time on this slide. It's the same slide, except, of course, that must be a lean PCOS patient, no hirsutism, no acne, and then that doesn't, we don't see that. So here are the three different ways we looked at PCOS. In NIH in 1990, they had these three major categories, or two. The Rotterdam, which really was the one that was around for the longest. The American Endocrine and PCOS Society came out with another one, but I will tell you, and I'm going to jump over it to just show you, this is where we are in 2023, and it is simple. There are 4 phenotypes, 4 ways PCOS patients will present. And we'll go through them. In PCOS-A is classic. Irregular periods, hyperandrogenism, if you have an ultrasound machine hanging around, polycystic ovaries. And yep, they meet the criteria. But guess what? In B, you could only have irregular ovulation and hyperandrogenism with a perfectly normal uterine ovarian ultrasound. In syndrome C, you don't have a perfectly normal ultrasound, but you also have regular periods. And then finally, in the D phenotype, you have just irregular periods and polycystic ovaries, but no hyperandrogenism. This is good and shouldn't be, this is good for Western medicine docs, because you don't see this. You see everything else. Liver cheese stagnation, you see those kinds of spleen deficiencies, you see that. But for us, this is a miracle, because now we can see and collect and understand better who our patient population and why it's a syndrome as opposed to a disease because of the variability. But for me, this is what made it so important. You can now, in the back of your mind, go through those phenotypes and say, if we're looking at insulin resistance, glucose intolerance, and diabetes risk, if you can categorize them in the A and B, this is a major concern, whereas down here, not a problem. That's cool. That's powerful. That's how to segregate and organize how patients come through your clinic and what you have to do about it. Because this manifestation doesn't apply to all who may have the predilection for some of these other dysfunctions like hyperandrogenism and just changes in the morphology of the ovary. That's huge in our industry. That is absolutely huge. From 3 simple things to now phenotypes with different morphological or phenotypical or biologic expression. But where it's pointing to, and you guys have heard it already, I'm not going to elaborate on it, is oxidative stress and inflammation. Everything in diseases are coming back to that. This is actually a paper on Tai Chi in the management of oxidative stress and low inflammation, low levels of inflammation. And what is it saying? It's basically saying you do have a genetic component, but we're back to it. Lifestyle, we're back to it. The influence of eating, creating androgen excess, how it impacts IGF, the management of insulin growth factors in the body, comes back to insulin. And what does it express? Obesity, insulin resistance, vitamin D deficiency. Your PCOS patients, almost by definition, 50 minutes? Okay. Almost by definition, are going to be vitamin D deficient. I'm lying. And then immune dyscrasias. Okay, where am I going? This is, again, this is the Tai Chi study, which just talks about the various disease entities associated with that. Menstrual cycle, very clearly, this is normal. And what do you see? Ebbs and flows. You know, Dr. Duncan was talking about, you know, the circadian rhythms. This is a lunar rhythm. Just so you know, this is a lunar rhythm. It goes over 28 days in terms of the secretions of our hormones. But like a flat line on TV, you know, get the, you know, thump them with the, you know, with the cardiovascular thing. Their hormones don't vary. They're just stuck in that preantral stage and they're not going through this. So why? Think about it. What in Chinese medicine do we understand about the menstrual cycle? Because it may be a surrogate point. When it goes flatline, what can we do? And by managing maybe this, we'll get that. You do it all the time with herbs, Qigong, as Dr. Mao said. Okay. I'm going to go back. I'm just going to, I got to go fast here. Sorry. Just so you know, there are 4 or 5 slides on an interdisciplinary what is the word I'm looking for? Multidisciplined approach, which basically says holism, integration, east-west, but it could be many different things from yoga, nutrition, and acupuncture. This was a very nice slide of showing how to approach in an integrative fashion. I did this 20 years ago. Not that I'm bragging, but this is something that I thought about, and I love seeing that it's being expressed here. Diseases are specific, syndromes are more nebulous. The word syndrome in Greek means concurrence, so it happens concurrently. Dr. Mao did a fantastic job of going through the various types of how syndromes, but what I want to show you is, this is a paper and it's in your syllabus on the biologic basis for your descriptions of syndromes. And I'm going to let you just look at this because I want to get to one slide. But in this paper, which is really good, there are these images which I found to be very helpful in understanding from a TCM perspective on how to approach patients and what to do. But guess what? If you looked at this Western medicine view and this now traditional Chinese medicine view, the overlap is obvious in terms of how you see and we see things. It's exactly the same. And again, I did the opposite. So here I'm saying there's the cross, but here I'm saying using the caduceus on this TCM pattern classification, how we look at what we call this PCOS syndrome. And then here, which was their way of treating, I put the Western medicine and Eastern medicine, or traditional Chinese medicine here, and said, okay, how do we approach it? And why not? It's all there in really, it's all there. I'm just going to stop here in a second because Dr. Mao did a great job on these papers. So why is it important? It's important because of all of these issues associated with insulin resistance are almost concurrent with PCOS. And in conclusion, very bottom line, integration and multidisciplinary approach to PCOS have shown promise and need further exploration by Yosan graduates. Anyway, thank you. Sorry.
Thank you, Dr. Mag. Hey now. Hey now. Our own Dr. Namin has a question.
Oh.
Thank you, Dr. Mike. I have a question. I remember we have a scoring system for hirsutism for PCOS patients, right?
There is a scoring system for PCOS patients.
What is its clinical application or treatment protocol?
Excuse me.
What is its clinical significance for this?
Oh, the significant, no, just it's a way of us, well, in our defense, it was a way of us even before insulin resistance was a thing. In our defense, it was a way of understanding hyperandrogenism in the PCOS patient. You managed, in my world, the hyperandrogenism. In your world, you have a different view. But that's what that is. And I no longer are concerned about it because a little or a lot, it's the same pathology is in place, which is insulin resistance. The worse the insulin resistance, the more you're going to see acne. Why? Insulin resistance causes more androgen formation in the ovaries. You then can get acanthosis nigricans under the breast and the groin, blackening of the skin becomes very hard. You'll see skin tags again associated with insulin resistance. That's just a marker of the level of the pathology. That's how I use it.
Any other? Oh, lots of questions.
One more. Oh, sorry.
Nope. I'll go forward.
You could ask me
Thank
about.
Thank you for a great talk. I
Oh,
wish I
thank
could
you.
have heard the whole thing. I need clarification on a very basic concept. So I heard you say that PCOS patients shouldn't wait too long to conceive while they're making these lifestyle changes. And so my question is, if they have a high AMH, then how do you counsel them on what their ovarian reserve is?
Okay, they have a high AMH because they have follicles that are secreting AMH stuck in the secretory phase of their existence. So they're real. They can become mature ovulatory follicles. So I say you have a very high reproductive potential. However, in your PCOS patients, 50%, typically in an IVF patient who has PCOS recovery. So if I recover, I'm 30 years old, I recover 18 eggs from a normal person without PCOS, and I recover 36 eggs from a person with PCOS, they still both only have 12 eggs that are going to make a baby. So even though they make twice as many, half of them are not as useful. And by the way, I said obesity, not PCOS. That's what I was describing as the weight loss component, not PCOS to weight. I don't think I said that.
Okay.
Yeah.
Is it? Oh, yeah. I interpreted it as PCOS with obesity, but
The obesity being, because that's what the doctor is going to say is you need to lose weight. They're not going to say you need to change it to somebody else, without PCOS. So I'm sorry, I'll talk to you after. It's
okay.
a little more complicated.
I have one quick question. So the patients who make these lifestyle corrections and their like fasting insulin goes way down, does their AMH level change, or would they always have a higher AMH?
What do you think?
I would think that they'd have some damage from oxidative stress.
No, what do you think about their AMH level? Would it change?
It's going to go down.
It shouldn't change.
But
it doesn't change.
it shouldn't change ever. Okay.
Not really.
Oh, okay.
Not
okay.
really. It's too subtle. It's
Okay.
That's too subtle, too short term.
Okay.
Yeah, it's not really going to change. They typically stay high, and as they age, of course, it goes down.
Yeah, so they can have a normal
Yeah,
AMH.
don't
when
worry
they're-
about the measurements. Worry about
Okay.
ovulation
Mhm.
and pregnancy.
Okay.
Don't worry about the measurements.
Okay, thank you so much.
Of course. Sadhna, are you still awake, Sadhna? Just want to make sure. Oh, yeah, there you are. Good. Okay.
Hi, Dr. Mag. Thank you for a great talk.
Who's talking? Oh,
I
there
am.
you are.
Hi.
Okay.
So my regular PCOS patients who aren't fertility patients are starting to get prescribed GLP-1 meds. And I was just wondering what the REs are thinking about prescribing that, or where they are in like this frenzy.
Okay,
that
tell
is.
me why you think they're giving them these GLP-1 drugs.
Because it helps with obesity, but it helps with their insulin resistance.
Okay, it helps with the management of insulin, which is translated to a weight loss in these obese patients. If you can get your patients to lose 5% of their body weight, so if they're 400 pounds, 5% is 20 pounds, they're going to start ovulating. They're going to get pregnant. Wait a second, but they're not at the lean body mass and they're not at the perfect BMI. The body doesn't care. It looks at the change. It changes the amount of floating around glucose, which changes the ability of the cells to do their job, which changes the amount of androgen that's being secreted, which changes the block in the development of the follicle, which allows them to get an LH surge, which allows them to get pregnant because they've ovulated.
So do you think more REs are going to start prescribing this for their patients?
Hell no. The patients are going to take it on their own at the little clinics in the mall. That's what they're going to do. Yeah. Peter had a question, I think.
Hey, Dr. Mag. Good talk.
Hi, Dr. Harvey.
Tons of information as usual, which is good.
Sorry.
No, it's quite all right. So in my practice in Chicago, I would have to say at least a third of my practice is PCOS that comes through my door. Of that third, though, 18, 19 years ago when I started in practice, that's what I saw was the classic heavy PCOS, hyperthyroidism, insulin resistant, polycystic ovaries, everything. But what I'm seeing much more now, 60% of the PCOS group that comes through are the skinny PCOS. You don't see the cysts in the ovaries. You don't see the hyperthyroidism. You don't see, so how they're kind of diagnosing it now is, well, you've got a really high AMH, which I would like to get your thoughts on what you would consider a PCOS range of AMHs.
Above 6.
Okay. And no androgen excess, but they don't ovulate, yet some do sometimes ovulate at times. What I've also noticed is that what doctors are still doing with these really thin PCOS patients is they're putting them on metformin.
No, I didn't get into the treatments and I apologize.
And that's something that's always, is it because they're trying to help the ovaries, with the dysfunction that's taking place in there? But, in my medicine, my treatment changes dramatically from a thin PCOS to a heavy PCOS.
Yeah. I was hoping that one slide which showed you, and that's the answer, by the way. The quick answer is why 65% more prevalence is dietary lifestyle, whether or not they're obese. There are many athletes who die of heart attacks because they have a dysregulation of insulin, they have atherosclerosis, and even though they're fit because of energy dynamics, physics, their physiology is saying, this is bad, this is inflammatory, this is oxidative stress, and in that case, I would be surprised how they're defining, if they're only defining a person as being PCOS, as having an elevated AMH, that's like saying, the only people who can play in basketball are 7'3". You could be 7'3", not because you have some acromegaly, you could be 7'3" because your parents were all 8'1". So it's too general, honestly, but I think the increased prevalence is lifestyle, diet. I know we have
Dr. Mag, for the PCOS phenotype slide that you had on page 29, I just want to understand this correctly. So C and D are not insulin resistant.
Less.
So the higher androgen for C is not because of insulin resistant. Can we say it's because
No. Look at how this is not a thin line.
Oh, okay.
No, I'm just saying there's a continuum. Not at all. So this person may have slightly higher
Okay.
insulin resistance. I'm sorry if that was a mis.
Okay, no, just I misunderstood. And what's the best blood test for insulin resistant?
None.
Oh, A1C.
The
no.
test you could do could kill somebody, so it has to be done in the hospital. It's called an insulin clamp test. Nobody will do it because it doesn't have to be. Why? Pinch an inch over 25. You have insulin resistance.
Okay.
Now it's general, of course, but yeah. I know you have to go. Oh,
Yeah, so it seems to me, and tell me if I'm wrong, that PCOS is nothing but insulin resistance, but you have different variations of insulin sensitivity. So their metabolism is kind of broken, but at different levels.
it's a component. It is not the only. There's a genetic basis for it. There's a familial basis for it. There's a lifestyle basis for it. I can use them interchangeably in America because quite frankly, the way we eat and what we do and what we see is enough for me to manage them and get them pregnant. But it is we can't say that it's, even though I put that on the left there, but it's oxidative stress, inflammation, poor dietary choices, epigenetic issues, environment, xenohormones, pesticides.
Right.
It
But
isn't that
still is a
simple.
metabolic syndrome. They
There is a
all have
component, a very strong.
variation,
Yeah,
various
these may
degrees.
not. That's my point.
Yeah, okay.
Last question. So do it as a duet. Ask the questions together and I'll see which one I'll answer.
Well, thank you, Paul.
I
This
got
was
it.
excellent.
My pleasure.
I just wanted to clarify, because people are asking questions about AMH, that AMH is not really a diagnostic factor for PCOS.
Not at all.
Correct. Yeah, I
Correct.
just wanted to clarify for that,
Yeah.
for this group, because.
No, it's just you can see elevated AMH, but in the criteria it has nothing. There is nothing on here that says elevated AMHs. Nothing. Thank you. That is a really good clarification.
It's also more with the hyperandrogenemia. I see that the docs are giving a much clearer diagnosis because, as us in my practice, I'm not really diagnosing. I'm support,
Right.
So I'm not telling the patient, oh, you have PCOS. I'm saying it appears that it's a possibility, since we are looking at everything, that it's possible you have hyperinsulinemia and you have hyperandrogens, and based on all these measurements and the looking and the diet, and we can coach them. But yeah, these lab tests change.
They do. And
And
and the markers change.
A quick comment on the luteinizing hormone being really off in PCOS patients. In a clinical setting, it's oftentimes very challenging for them to get any clear-cut ovulation prediction on their ovulation predictor kit, which can be very, very challenging for, especially agreeing with Peter, there's a lot of the thin, skinny PCOS. They may be regular cycles, maybe just a little off from a textbook 28-day to being more 36 or 40, but for them to establish that ovulation gets to be very challenging. I know
They don't work. The ovulation prediction kits simply are not
exactly, and on
PCOS
the
patients.
same LH up and down, their cervical mucus could be also not a very good indicator for PCOS. I know with the Western medicine, it's not so, doesn't put emphasis much on the basal body temperature charting, just because it could be so variable with so many different environmental factors. But in clinical setting, I do find that when they have no other option, if they are doing their charting, they can have some semblance of knowing when their ovulation has happened, if they do ovulate. So just wondering if you would want to comment on that.
Yeah, your basal body temperatures can't work. Your LH, in my mind, Sadhana, the basal body temperatures can't work. The LHs can't work simply because what the basal body temperatures are marking is, here's your basal body temperature. What is that graph looks exactly like this one. And the only way you get progesterone in the human body is through ovulation. There's not even a tumor that can do that. So, and if I disagree, but it can tell you changes. this I can change. I'm so sorry I'm taking so much time here. Because this is where the pathology is in a PCOS patients, where you see elevated LH because you have this altered sex steroid secretion, because you have this in the aromatization of the androgens to estrogen in the obese patient, because you have this increased pathway to two types of androgens, both from the adrenal and the ovary, which is not showing you that here, because you have insulin resistance. Thank you.
Thank you, Dr. Mag. Now, if that talk was interesting to you, Dr. Magarelli will be teaching in the doctoral program in October, an entire weekend of metabolic syndromes, PCOS, and there's still time to enroll for the May cohort and the September cohort. So if you'd like to spend more time with Dr. Mag, I highly recommend doing that class. Let's just take a 5-minute, all the clocks have a different time. Let's take a 5-minute, stretch your legs, go to the bathroom, go buy all the products from our sponsors, Koala Herb, eFung, Theralogics, Healthy Seminars, Fat Turtle, and we'll see you in 5. Thank you.
I can't help it. I know. Yes.
So can I just count 14 days of the last period as their operations?
There's two phases in the menstrual cycle,
Yeah.
the follicular phase and the luteal phase. Which one?
I would imagine PCOS to have a long.
Which one varies? Between you? No. Well, we'll go back. 28-day cycle. 40 days. Which of these varies? Luteal phase get bigger?
Well, I was.
Follicular phase.
Deb and I were at dinner last night.
Well, because they're ovulating.
It is the follicular phase.
Yeah.
You
Want to
want
record it.
Yeah.
Absolutely. So go back 14 days.
Do it.
That's when they come.
So the PCOS patients with a higher LH include that as the
If they have a period regularly irregular.
Yeah. Okay, so they can report regularly 45 days.
Yes. Don't be afraid if that person's basketball again is 7 foot versus 6 foot. Just because it's 35 days do use, but even the PCOS patients get confused. They believe bleeding is a crucial.
Yes,
Yeah, it's not the
always,
same.
not the same.
It's bleeding. You can cut the vagina and it will bleed. If you cut it every month, it'll bleed, but it's not a period. It's ovulation that defines the period. So you have a period and you go back, and you have a period and you go back, and it's always the same. I'm gonna say, she's not working. Yes.
Okay, we all came together.
The answer.
This is like a gag.
We wanted to, James formulated a great question, so we don't need to.
I know, so you said, I found a space for me today on your thing was that I was excited that when you're secreting too much insulin, it sends the signal to the ovary, and then the ovary is secreting the IgE, and that creates like fat.
In the ovary.
All right, so I'm going to call somebody.
Androgen production in the fat. Yes. Androgen for any growth factor. Let's go back to the growth factor, which is insulin. Will shove the glucose as excess in the blood to make fat. The fat itself will convert as you grow into diet. Will then feed back to the brain saying, I don't need any FSH. I don't need any FSH.
And you think that produces okay, that's what I'm thinking.
When you run an ultrasound, does it look like there's a wax coating? You were still talking about the peach, right? Is that
If
visible?
you were to take the ovary out, it would be hard and dense, and you would call it fat.
That's what we're asking. That's why I was kind of like,
I guess in your
I heard
medicine,
that and I was like,
you would call it fleming. It
Yes.
literally looks like cough, like someone spit and.
Yes, like a
loogie. Yeah, a loogie, that's the word.
I will never forget that.
That's why I'm here.
That's why a lot of PCOS.
That's why I'm
the syndrome can fall into the damp.
Yeah, for me, the
Even
more
if
I
they're
see Diane
skinny,
and your
even
stuff.
if they're skinny, they
Yes.
don't have the obvious.
It's phlegm.
Yeah, it's damp.
It's congealed something.
It's a
But
It's like
when I treat atypical PCOS, I mostly am looking at inflammation rather than conditions. It's a different biomedical process. There's more that's
more inflammation. Endometriosis, PCOS, come back to our best understanding of inflammation.
Yes.
Our best understanding
I
of
think that's the
oxidative
biggest
stress.
change.
Our best understanding.
Right.
Because all of those, and this is what pisses everybody off, are managed by lifestyle choices. All of them are managed.
And they're not touching that, there are other components. But I think this is inflammatory.
Hi. Can I help you?
My liver.
But a lot of times that's important just not for ovulation and regulation, but for pregnancy. People don't get that. Like I'm ovulating and I'm not ready to cycle and it's not happened. And you want them to spend a little time to get ready for the pregnancy versus, oh, I think you're pregnant and then you miscarry because that's
Remember when Duncan was
stuck
talking about
follicle.
lift, he said, what is it? It's leukemia inflammatory factor. It's a cytokine. And cytokines are the suit that can do damage to metabolic processes, to how mitochondria use energy, to how proteins are made. Right? It has such a complex, multifactorial.
Here, come in here with me.
That's how we have to attack it.
You look so nice.
Make me look skinny and young.
Yeah, he does good. This way? Okay.
I'm not a big fan of that. I don't think it's a panacea.
But don't you think they use it just
Thank
Thank
you.
you.
Awesome.
What is your title and role at USU? I wrote the recommendation, you got the gig.
I didn't get it.
I can tell you in the
And then I won't mention it.
Please don't.
Then I won't mention it.
Yeah,
So
no,
I'm gonna
I
stick
didn't-
with the bio. That's
I didn't keep up with my childbirth certifications, and I thought that my acupuncture license. So anyway, so they said no. I was a childbirth educator certified through hypnobirthing, but I didn't continue the CEUs because it's enough with acupuncture. So I was like, whatever, I have the education. I had no idea. Yeah, they were like, oh no, we can't hire you. And they sent me the contract and everything. So.
what was what's the course look like for that?
There's different styles of patient management.
Huge,
That's what I
because
said. Individualization, or efficiency.
And I just told.
I honestly don't so busy. Can you put my PowerPoint out here, or is someone else gonna load it? Or okay, cool.
Sneak in here so that I can learn how to do this because I haven't
Oh,
actually
okay.
done an in-person talk since pre-COVID.
Awesome.
So I'm gonna. How you feeling?
Nervous.
I know, but you're gonna do great.
Yes.
You got this. You talk all the time. You're professional. You're
I'm
good.
so nervous.
So I put you guys in presenter view.
Oh, that's so awesome. So I
Right.
can see my notes.
So whatever notes you have
Okay,
are
perfect.
there, and it's just left, right.
Okay,
I
perfect.
needed to know if I need to wear my bifocals or not. I'll take my
I do.
contacts off. I'm gonna have to go get my. Because that's why
So
I'm
I was
actually
like,
coming up
I'm
here. So I'm
here.
doing research on whether or not my progressive lenses.
Awesome.
And you can kind of, if you
Oh, I can make
if
it
you
bigger.
don't have a
Oh,
lot of notes,
lovely.
you can make your slides bigger. If you have a
Okay.
lot of notes, you can kind of
It's
come that way. So it's totally up to you.
Yeah, I'd rather make the words bigger on the notes.
On the side,
Yeah,
so
if
yeah.
that's possible.
Yeah, just go ahead. I tend to
And
go
I'm
half.
35 minutes on the dot.
That's
I
what I
practiced so
heard.
many
I love
times. I'm on.
Oh, you're so
Yeah.
good.
So Felicia was like, she's good. 35.
Yeah,
Don't worry.
don't worry. I got
It's
it.
supposed to be 35.
Yeah, 35, right?
I get lost in this. So it's this way and this way.
Yeah,
Somebody
yeah,
said, okay.
yeah. So, yeah, so nervous, and I have
No, yours is so
this.
good
and-
because we're coming off of something really heady, which was great and it was fantastic. But I know that what you're going to bring is just a change in the energy. So it's going to be a nice. Well, mine is. I'm worried about it because
This
mine
is David.
gonna-
This is my boyfriend.
Oh,
This is Jamie.
Nice to meet you. Nice to meet you. Wonderful. Yeah, mine is so different. I'm like, Deb's going to change it up. And then we're going to kind of have a couple more normal ones, and then it's going to be me, and then it's going to be. Sorry, guys. Like,
I don't think you have anything. Yours always such a great story. storyteller.
Well, it'll just shift the, like, good or bad, it'll shift the energy. And same with, like, yours is gonna be just like next step.
Yeah,
This is gonna
it's
be good.
definitely, it's not like any other talk at all.
Mine will.
It's not as edgy.
No, but yours is still brass tacks. So
That's
mine is
right.
mine
There's
is
no
gonna go
words
off.
this long in
Mine is gonna be off the deep end esoteric without pictures, and it's gonna
Okay.
be like a 1990s esoteric college level
College
religious experience. It's not. Anyway.
Anyways.
We don't.
Okay. I'm ready. So do we have a full audience today, or there's less people today?
So let's start coming back. Was that an ABOR meeting? Was there a quorum for that meeting?
Yes.
All right. Welcome back, everyone. I would like to introduce someone who's awesome. You know, I'm in touch with a lot of the industry, a lot of the other deans, talking about graduates of other programs and trying to find as many amazing faculty members to bring here to Yosan for the doctoral program and for the master's program. And two of the names on today's list have just kept, they keep coming up. They keep coming up. Every person I ask is like, have you talked to Deb Davies? Have you talked to Jamie Boyd? Like, those are the two names that are just like, you know, like if you're into sports, right? And it's like they're recruiting. It's like, oh, have you seen so-and-so play? Have you seen so-and-so play? And Deb and Jamie are two of those people. So I'm ecstatic to have both of them here. Deb already teaches in the doctoral program, and I'm slowly bribing Jamie to come forward, to come up from San Diego. But Deb has been teaching in our doctoral program already. She teaches all about women's healthcare and wellness, birthing, postpartum, pregnancy. She's really, really well informed and experienced. So I won't belabor it. Let's do Deb Davies. Welcome.
Thank you. All right. Well, thank you, everyone. I am truly honored to be here, invited back a second time to this conference. And my talk is going to be unlike all the others. This is going to be a deeply personal talk, a deeply emotional, and I'm going to share lots of pictures. These pictures that I'm sharing are from my own experience and from experience with my patients, have all given me permission to share the work. So my topic is confidently treating pregnancy with traditional Chinese medicine. So I want to start out by just telling you guys a little bit about me. I began in the TCM field. Thank you. I'm a little short. Perfect. Awesome. Better? Okay. No worries. So I began in the Chinese medical field back in 1996. I was living in Pennsylvania. I worked for a woman named Kathy Goldstein. She was an acupuncturist, and I was truly floored about how she was able to help so many people. And I was working as her assistant. I helped her office grow. And then I moved out to California. I met my husband. I got pregnant. And I didn't know anything about pregnancy. I was really, really excited. And so I'm going to share a story of what happened to me. And it's really sad. So this was my baby. I had a stillborn at term 20 some odd years ago. She was stillborn due to a cord accident, and this rocked me to my absolute core. And this is why I'm so freaking passionate about helping provide natural options with women during this time. So I did go on to have another baby, and it was the greatest blessing of my life to have my daughter Lauren a year later. It really helped me. I began PCOM when I was pregnant with her, and that's the Chinese medical school I went to. And when I was pregnant with Lauren and with Mia, I noticed that people really treated me differently as when I would go for acupuncturists. I would say I have back pain, I have hip pain, and they barely touch me. So anyways, I continued my acupuncture education. I started in PCOM. I did all of their programs. And when I graduated in 2009, I began Push San Diego, my integrative clinic in San Diego. While I was in school, I started my DONA training. So I chose DONA, it's for Doulas of North America. I chose to do this program because it had the highest standards for training for doulas. And when I did all of the training, and when I went to certify, there was a clause, and it said, if you have a medical license and you're serving as a DONA doula, you cannot use your medical license. And I was like, what is that? Everybody hires me because I'm an acupuncturist. So then I went and I studied hypnobirthing. Hypnobirthing, that's where I got my childbirth education certification. They teach physiological birth, how to get through a natural birth. And that resonated with me in my Chinese medicine training. Anyway, I did that in 2014. So around then, I live in San Diego and there's a million acupuncturists. So I really want to stand out against all the other acupuncturists. And everybody specializes in fertility, that's in women's health. So my interest is pregnancy, birth, and postpartum. So I sought out specific teachers. Who do I want to study with? I flew around the world to study in conferences and with people. So I had the honor and pleasure to study with Claudia Sikovits for a couple of years. I did all of her trainings. My last training was her 50-hour intensive at NYU Hospital, doing acupuncture and labor and delivery. It was mind-blowing, rocked my world. And I brought two of my colleagues. This was a picture of our first C-section. And then this is also kind of cool because I began Chinese medicine 20 years prior to this. I would have never thought I would have been in labor and delivery doing acupuncture at a hospital in New York. Amazing. So we've really come a long, long way. Just a little bit more about me. I started teaching here about 3 years ago. In 2020, when it was a pandemic, I finished my doctorate at PCOM. I also became published author. I started teaching at online for Net of Knowledge, and I started Push Professionals, a mentorship program last year. So I have some questions for you guys online. You can put it in the chat, in the audience. So how many of you have been practicing less than 2 years? Who's my newbies? Just a couple. So how many have been practicing more than 10 years? More than 20 years? Yeah, still more people. Yeah. And how many of you treat confidently when you're treating your patients? Feel actually, truly confident? The people with 20 years experience, of course. But what I'm seeing from going to teaching at different schools around the country is that not a lot of people are really confident. Not a lot of acupuncturists are really confident treating pregnant patients. So I'm determined to teach you why we as acupuncturists play such an essential role in treating pregnancy and help you acquire all the tools that you need to feel confident in supporting patients through their entire journey of pregnancy, birth, and postpartum. So what I've seen is that most acupuncturists are afraid to cause a miscarriage. They're afraid to move blood and qi. And this is happening a lot in our world. And the fear of them treating is stronger than them actually treating you. I know that because I started pregnant, and the way I was treated when I was pregnant was so different. And people are concerned about the malpractice if you were to, have a miscarriage or anything. And so even one of my mentors who has 30 years in the field told me recently, like last month, that she used liver 3 on a pregnant patient and was terrified. I was terrified. So I'm like, wow. So I really want to share with you how TCM is so helpful in pregnant conditions. And women need our support. They really do. And we need to step up to the plate in terms of getting our confidence up, reducing our fear so that we can treat pregnant patients. And it's things like this conference, doctoral programs, research that really make the difference in our field. So it's really a great time for acupuncturists. So these are some of the topics we'll talk about. I'm going to do some statistics of what's happening, some research, and I'll talk about some basic things for people who are not treating pregnancy and clinic things that you could have, as well as some pregnancy disorders that TCM supports. And I'm going to share some stories and tricks and tips. But I really want to teach people, I really want to empower acupuncturists to stop being afraid of needling pregnant women. So my question, did you learn everything not to do with pregnant patients in school, but not how to properly care for them during pregnancy, birth, and or postpartum? Again, in most of the schools, we're taught what to avoid, what not to do. Students are terrified of treating pregnant women, and this is across the country. So when, like I told you, when I was pregnant, people didn't really want to touch me. I found that when I would come in for pain, I'm like, that was not even a treatment. Like it feels so frustrating. So I think it's important to seek out your teachers to learn from and schools to learn from so that we can gain the information that we need. So does your fear of treating pregnant patients stop you from treating them? Again, a lot of people feel like it's mysterious and scary, especially if they haven't had a baby. You know, they don't have that experience. They refer them out. And even in San Diego, where there's a million acupuncturists, other acupuncturists would refer me their pregnant patients all the time. So this is what I see a lot. Are you really great at treating fertility and helping your patients get pregnant, but then you refer them out? Again, you are missing business. It is ridiculous that acupuncturists would refer to me only instead of you. You know, I really think that people need to learn pregnancy as a specialty. Fertility is such a big thing in Chinese medicine. What about pregnancy? It's not just about getting them pregnant, it's about helping them carry to term, to have a successful, birth, to be a healthy mom after giving birth, to recover from postpartum and be able to get pregnant again. So now I'm going to get into some of the statistics that's happening in the United States right now. So every pregnant woman is eventually going to give birth, right? So my concern is that a lot of labors are being managed. And instead of having physiological births, natural births, there's not a lot of discussions over how someone is going to give birth. If a woman is uneducated and she thinks she's just going to go along with the plan, it's kind of a scary world out there. So this is showing rates of inductions have risen significantly. And here it's saying 25%. In my practice, it's probably 40% of the women are being induced that have OBs. So this slide, it talks about C-sections. So we have about a 32% C-section rate in the United States. That is 1 in every 3 women are giving birth via major abdominal surgery. The World Health Organization says 10 to 15% is a normal, healthy C-section rate for a country. And when I was born in the 1970s, our C-section rate was 7 to 12%, currently at 32% and rising. This varies hospital to hospital and state to state. There's hospitals in LA that have a 70% C-section rate. Yeah, and this is just showing from 22% in some states to over 35% in other states. So I'm going to show you a little clip of a documentary that came out many years ago. And this was from 2007, and this is called The Business of Being Born. So it's a little 2-minute clip, and I'm not seeing it pop up here. Are you guys able to help me with that or anything? So basically all pregnant women are going to give birth. And so at some point you have to prepare them for giving birth. So my IT people, can anybody help me? I should have a link. Is it the next slide? Okay, perfect. There we go. Let's see if that will work. Ooh, all right. So it's a 2-minute video. It's definitely worth our time. So I'm going to share it.
Since that there's no audio, you gotta come here.
Oh, okay.
Hospitals? No.
Can I do that? Can you guys hear anything? Is anything being heard? Okay. Okay. So I want you guys to watch this link, because what this link shows is the statistics of hospitals and what's happening in the hospitals today. And hospitals are businesses, just like we're all in business too. And to have a natural physiological birth, there's not a lot of money in it. Women are being routinely induced, routinely C-sected, and there's not a lot of conversations for some doctors. I know that not all doctors are bad. That's not what I'm saying in any way, but the concern is that there's a lot of problems with managed care in labor and delivery. Women are coming out talking about birth traumas and so on. I need to find my PowerPoint again. I'm sorry. Can someone help me so I can go back? Anyone? Okay, never mind. We got it. We got it. All right. So basically, I just wanted to share all these things. And unfortunately, you should watch the video or it came out in 2007. And in the video, it says the United States has the second worst maternal mortality rate in all developed nations. Well, I'm here to tell you we're officially the worst. We are the worst with our maternal mortality in the world of all developed nations. 24 out of 100,000 women are dying in labor. Why? We have all this technology, all this money and development and research. What is going on? What is happening? And the rate is rising regularly. Every year, recently, it is going up and up and up. And if you are a Black woman, a person of color, you are 3 or 4 times more likely to die or your baby to die in and around labor. So we need to share that with our pregnant patients, with our African American community. People need to be aware of this, not for fear, but to empower them so that they can make the shifts and the changes that they need to make a difference in their labor. So now recently, I gave a talk to a group of Israeli acupuncturists. So I researched, what is the Israeli maternal mortality rate? It is 3, and it's down from 6. So they are doing things right. So I taught a class on acupuncture and labor and delivery to these acupuncturists in Israel. And I said, can you guys share something with me? What's happening in Israel that I need to know about that we need to do in the United States? You know what's happening in Israel? There's 8 acupuncturists in every single hospital. There's acupuncture departments in every hospital. They handle the emergency room. They handle labor and delivery. They handle post-op. Can you imagine if we had acupuncturists in all the hospitals and how that might be able to shift? It's very, very, very important. So my point is there's so much we can do with Chinese medicine around pregnancy, birth, and postpartum. There's a very high success rate and patients love us. It's so cool to have continuity of care. You see a patient all the way through their fertility, then you also see them all the way through their pregnancy, birth, and postpartum. Make sure they're okay. A lot of people aren't taught this. And again, every woman is going to give birth eventually. And we really need to care for women during this time. Let's see. I saw an article last month in Acupuncture Today saying essential part of the pregnancy team, licensed acupuncturists. This is telling us there is a demand, there is a need. We need to step up to the plate. So now I'm just going to get into little intricacies. If you're not treating pregnancy, just a couple little tips and tricks that I find extremely helpful. You want people to feel safe and comfortable in your clinic. Having an adjustable table that goes up and down can be lovely. If not, you want to have tons of pillows, wedges, that kind of thing. I even went and bought a doorbell at Home Depot. It's great. I can put it in my pregnant woman's hand. If there's any reason you need me, if you need to pee, press the button, I'll come right in. I have different sounds in 3 different rooms. I know who calls me when they need me. It's wonderful. They feel safe with that. This is what 40 blinks are. It looks like a little face bra. This is great if you are treating women on their side. A lot of times we treat the pregnant women on their side, and then you can put a little tissue, cover their eyes. It doesn't mess up their eyelashes. This is also fabulous to have for birth. So they can kind of go within and just focus on their baby. This is what I like to call the queen throne position. This is a fabulous position for treating a breech baby. So this is with the adjustable table, but if you don't have an adjustable table to use a wedge or something like that, it's super comfortable. They love coming and getting treated. On the left here, this is how I treat most of my patients. On the side, they would have a pillow under their head, a body pillow between their legs they can hold on. I can reach one yin side of their leg, yang side on the other. I can reach their back. And the other picture is just me helping a woman who is about to go into labor, and I'm pressing GB30. We call that a double hip squeeze. And okay, so why are acupuncturists afraid? There's a fear of liability, right? They're concerned about needling pregnant patients. So one thing you might say is to set the intention. I do 20 with all my pregnant patients, and I call it the hold the baby in point. And when they come in the first time pregnant, we do 20, and I tell them, I'm gonna do that as the first point every single time while you're pregnant until you're ready to give birth. So that sets the intention, not only for me, but for them. We're not doing anything to disrupt this pregnancy. And if I would ever forget, they would be like, hey, wait, what about that point? And that's great, you know, so they're actually like participating in their care. The other thing is having the proper liability coverage. When I started out, I had American Acupuncture Council. They do not cover this. You are not covered if you have AAC, I'm sorry. So Claudia Sikovitz helped me find this place, CMNF out of New York. They cover you no matter what for pregnancy, for birth. I'm a doula, I attend hundreds of births. I can be in a hospital doing acupuncture. I can be in California, New York, I'm covered. So I really like that, appreciate that, because I'm mostly pregnant patients. So here's some of my tips for treating pregnancy. Keep it simple, diagnostically. Tongue and pulse, treat what you find. Limit 10 needles. You don't need 25 needles. This is especially for the newbies, because they're always like, oh my God, so many points. Make sure that patient feels safe and comfortable in your clinic, and include the partner if you can. This was beautiful during COVID, where a lot of the clinics were closed. I would always invite the partners in, and I would show them points that they could do. And they were like, thank you so much, because they really need the support. People need us. So these are just some of the things that I treat successfully during pregnancy. And I'm going to go through a couple of these with you. I have a couple of stories. So hold the baby in. So all your fertility patients that are spending tens and hundreds of thousands of dollars through their IVF and everything, it's so wonderful to be like, sure, we do the hold the baby in treatment. Once a week for the first 12 weeks, they love it. It's very reassuring to them. I treat a lot of breech, probably at least an 80% success rate with turning breech babies. This is how I would do it. I do the UB67, just like we're told to do. Works. So this is a slide on IUGR. This is when babies are in 10 percentile or less. And so this woman, this is my patient. She comes in at 20 weeks pregnant, hysterically crying, telling me that her doctor told her her baby was going to die. And her doctor said, if your baby doesn't die in utero, it's for sure going to die during the birth. And if it doesn't die during the birth, he's going to die shortly thereafter. Okay. I treated this woman every week. Sorry, I went back one. I treated her every week from 20 weeks. She spontaneously gave birth at 38 plus 6, had a successful baby, boom, no problems. Beautiful, tonified kidneys, tonified blood, lots of moxa. Placenta previa. Placenta previa is the only disease that I have 100% success rate treating. And nobody talks about placenta previa. Placenta previa, most of the time, the standard American diet is horrible. Their spleen is deficient and their spleen chi is sinking. Bujang, tonified spleen, talk about lifestyle. This was one of the many, many women I've been able to help during placenta previa. So that when you have placenta previa, it's an automatic C-section. And if it shifts, then they get to do a vaginal delivery. So they're thrilled at our support. So pregnancy loss. Outside of the first few months, I don't see much information on pregnancy loss. And if 1 in 4 pregnancies are ending in loss, there's trauma. It's trauma to the women. And whether it's a miscarriage, if she's 6 weeks or 6 months, that's her baby. That's her future. So I'm teaching pregnancy loss. I have a class coming up soon. I teach on Net of Knowledge. This is the QR code talking about how to aid and treat during pregnancy loss, the different types of miscarriages, recognizing abortion as a loss, you know, what to say, what not to say, how to potentially prevent a miscarriage, and how to support mental health during pregnancy. Okay. So next one is on, well, this is another story of pregnancy loss. 13 weeks, I get a call. Someone calls me on a Sunday night. I had been attending Pacific Symposium, just took a class that day, how to prevent a miscarriage. Jill Blakeway. This woman calls me, I'm 13 weeks and my bag broke and my doctor told me to abort. I'm very religious. There's no way I'm gonna abort this fetus. Can you help me? I heard you can help me. I go to her house, her bag resealed per her perinatalogist. She carried to 32 weeks and this is her healthy baby, Hobie. And she went on to have another one. Beautiful. Acupuncture and doula-ing. So this was a woman, I attended both of her births. Her first birth, 48 hours. So long and arduous. She really wanted a gentle 8-hour birth, just like hypnobirthing teaches. And so I was her doula. I brought an assistant with me, another acupuncturist, and I said, look, so a doula is a non-medical role. So it's hard to be an acu-doula because you have your medical and non-medical hat on. And so when I would be by myself, I don't do a lot of needles during birth because nobody wants to be poked anymore. It works so great with just the acupressure. Maybe I do the bilateral points, that would be it. So at this point in this birth, I have Grace, my assistant, with me, and I tell her, you're gonna be the acupuncturist, I'm gonna be the doula. The woman gets out of the tub, she's 8 centimeters, she's miserable, she's trying for a natural birth. So I said, do the bilateral points. She did all 8. She gave birth 10 minutes later. It was crazy how fast it was. And this is a picture of her beautiful little family. So all pregnant women have to give birth. Our continuous support can help change a woman's pregnancy and birth from a fearful one into a much more positive experience. What would this do for our society, for family bonding, mother and child, mother and partner? And how can we help change that for them? And if not us, who? You know, there's so much satisfaction in patients and so many ways that Chinese medicine can help. So I want to just share, these are some of the ways I would help during birth. So to explain how Chinese medicine can work in a Western medicine setting. Every birth I've ever attended, 250 births, there is a decel in the heart rate right before the baby is born. And sometimes the hospital is ridiculous about it. And of course, I don't ever want to see another dead baby in my life, but they're like talking C-section. This woman's 25 years old. It's her first baby. She wants to have 5 kids, and they're talking about C-section. So did you know if you tap on UB67, pops that baby's heart rate right up? Tell your parents, tell the pregnant ladies, tell their partners. And the other thing that's super cool to see is LI4. If a woman's having contractions, she's in a hospital, hooked up to the tachometer, the monitor. If she's having crazy contractions that are just going jagged up and down, you squeeze LI4 and within 1 contraction, they normalize. It's amazing, amazing. I'm not gonna get into all these other things due to time. Some of the other things I like to talk about and mention is while you have a fertility patient, you mention what you can help with them while they're pregnant. While you have a pregnant patient, you mention what you can do while they're postpartum. I helped develop this little kit with ear seeds and the first 5 points for natural promotional labor. Also good for postpartum. This is an awesome thing to have in your clinic to share with your pregnant patients because we all know we see them a ton for fertility, a ton for pregnancy, and then they're really busy when they're postpartum. So, and then it's also worth mentioning, it's awesome to do house calls during this, so during postpartum. So in summary, most of us did not learn how to confidently care for pregnant patients, and this is really what we need. We need to share the importance of being confident, treating pregnancy, not just about getting pregnant, but keeping them pregnant, caring to term, having a healthy baby and a healthy mom. So I love to share this knowledge. It's really important that acupuncturists are confident. We really, really need to step up to the plate. And that's really, my biggest thing. So imagine a shift in your practice. You extend your knowledge beyond fertility by not only helping your patients get pregnant, but stay pregnant, carry to term, prepare for a safe birth, and then how to heal postpartum, and then repeat. So you need getting training so that that's not so scary. Imagine the what not to do for your pregnant patients becomes full of, this is how I treat pregnancy, birth, and postpartum. The fear of treating pregnant patients transforms into confidence. Imagine you no longer refer your pregnant patients. You're not losing business because you know how to properly treat them. And so I want to share with you a little bit about a program that I started, a mentorship, and it's on pregnancy, birth, and postpartum. I feel like it's the missing link because there's an abundance of fertility information, but we really need to be able to help these women carry them through. So I have one of my mentees. She's from Ohio, this amazing woman, just graduated acupuncture school, got a office in an OBGYN office. She said the OBGYN wants to open the floodgates on pregnant patients, and she's terrified of treating her patients. And so just in a couple of months, she feels so much safer. She's no longer terrified. And it was really cool. I had another one of my students get on a call one time and say, my wife's so confident, she's doing so great, and her business is booming. So it's exciting to be able to share this. So I want to invite anybody that's interested in this to join me in this mentorship. This is the QR code here. There's a special discount for Yosan attendees, and it's a 3-month program where we do one-on-one online calls every week, 2 hours on Zoom. And 1 month we talk about pregnancy, 1 month we talk about birth, and 1 month we talk about postpartum. I also do one-on-one calls. So I would love to share with anybody this information. Is there any questions? Anybody have any questions they want to ask? Yes.
Thank you, Deb. Let me get some microphones.
Sure.
Over
Okay,
there.
microphones.
And I'll share that I was also terrified to treat pregnant women until my own wife was pregnant and she was in labor for way too long. And I was in UCLA just hammering her on all the forbidden points.
Yes.
And after that, I was much more confident.
Yeah, after you have the experience, for sure.
So here's Dr.
Yes.
Harvey.
Hi, great talk, very energetic, loved it. I think you and I talked about this last couple days too, It's interesting, you mentioned placenta previa. And in my practice, I found I have virtually 100% success in reversing it. And I treat incompetent cervix pretty much the exact same way as I treat placenta previa. And I just kind of figured out some things on my own. So I kind of came up with my own protocol of how to do it. Same thing, I came up with my own quick protocol for first trimester, second and third,
Nice.
because of the volume we see, and then from there I can add to it and stuff. So I love your idea of do 20 because that's like my trademark. Even since I was in school, everybody gets do 20, unless they're the ones who have a lot of yang ascendants and some
I'm glad
people.
to hear that you like it.
All that's all I treat. Same thing. But how I treated placenta previa, and I'm wondering how much this may vary from yours, is I look at this as a weakness in the whole body. So I'll do 20. My second point I do is Ren 2, but I have the needle facing up towards the head because I'm telling the body, push the chi up, hold it up, roll them on their side, and then I am doing UB 23, 20, 18, 17, and I think 14, run them up the body to strengthen all the major organ systems, and then sometimes stomach 36 too for that extra kick. Is that close to what you do? And
Yeah, I would do like UB, let's see, 15, 20, 23, 18. Do 20. That would probably be one of my favorite. I do a lot of Ibuki spleen 3, lots of moxa. I would moxa up.
Yeah.
And here, if it's really scary, potential miscarriage, I'd also add Shishinkong.
Yes.
Moxa up here.
And my first trimester patients, when they come in right after the embryos are transferred, it's always do 20 Shishinkong and kidney in the ear, and that's it. Unless if they get symptoms, then I treat the symptoms accordingly. And
Yeah. Awesome. Thank you.
Great, thanks.
Mhm.
So just real quick, those points that I showed you yesterday, Fuke and Huan Chao, that combination helps prevent miscarriages. So look those points up because they're really amazing. Use them on every patient. Use them up through 12 weeks in my clinic so that the pregnancy is secure, just FYI.
Is there any other questions in the back? Yes.
If patients have taken a break from infertility care and they come in later, excuse me, later in the pregnancy,
Mhm.
so they've essentially not been treated for the first several months of pregnancy,
Mhm.
do you find that there is a time at which treatment could be initiated too late in the pregnancy to be helpful?
No, no, not at all. I would say that I get many, many patients come in for natural promotional labor. Never seen them in my life, and they're 40 weeks. Get this baby out. So I think that we can be helpful. I mean, time and time again, I've had story after story of how just that can help them, give birth, everything flowing. So I don't, ideally they're coming in pre-pregnant and you treat them all the way through, but it just kind of depends. I think that there's no too late point for sure.
Some questions from the interwebs.
Sure.
For Moxa, what Moxa do you use? Any concerns with the smoke? Things like that.
I have an air filter and windows in my clinic, so I do not, I have a concern over that, the smoke. I also ask them and make sure they're okay. I use smokeless in my practice. I use a lot of Ibuki, and then I also use Pole.
Thank you.
Yes.
Other than not having acupuncture in our hospitals, do you have any data on why we have such a high mortality rate?
I think that's a really good question, and that's something we can all ponder. Why? Why is there such a high mortality rate? Honestly, my thoughts is like policies and procedures, business. Hospitals are run as businesses, and a lot of times it's not focused on what she wants, what the patient wants. It's more about like logistics, timing, all of the setup, all of that. And so I encourage my patients to be vocal. This is not a good time to like lay down and just listen to your doctor. You need to ask questions. Ask, how is this going to go? Like, some people just assume they're just going to go along with everything the doctor said, including getting induced. And I listen to my patients. I ask them to come back after they give birth. Every time they come back and tell me their birth story. And I've had hundreds, if not thousands of women cry and tell me about their traumas and how they weren't listened to, and they didn't feel very good about the whole situation. And if our whole world is full of everyone was born at some point, like, we really do need to make a shift. And so I think acupuncture is stepping out more professionally into the world, into the hospitals, can make a difference. We can see it's happening in Israel. And so I think that's just something that we really need to do.
Thank you. Last question.
Sure.
Kind of a two-part question. How often do you recommend pregnant patients come to you? And do you do cupping on pregnant patients as well?
I do cupping. I do something called navel cupping. That's kind of one of my signature things. If I wouldn't do cupping in the orthopedic sense the same, if someone comes in with hip pain, I might do one cup. I don't do sliding cups with my pregnant patients. And then what was the other part of the question?
How often do you recommend they come see you?
I think it depends on what they're coming in for. A lot of times it's once a week in the beginning, once or twice a week early on, depending on their level of fear and what's going on. And then I would say once a week from about 34 weeks on, twice a week at 38 weeks. If they're up against an induction, come in every day, every other day, something like that. But it kind of varies. A lot of times I see them a lot in the beginning and a lot in the end. And then the second trimester, it's sometimes a lot easier.
Awesome.
Awesome. I just want to share one more thing. I do have some classes on Net of Knowledge, childbirth acupuncture. I have a postpartum class. I'm doing a pregnancy loss on the 28th, and then I'm doing a class on placenta previa. I'm also teaching a class here in May with Felice Dunas, and we're talking about trauma. And I'm going to specifically be talking about birth trauma. So that is it for my practice. Thank you guys so much.
Thank you. All right, we'll stay in the room and we'll bring up our next presenter, Carol King. While we're changing over, I'll mention, Deb and Felice are doing this CEU in May. Just before that, we have Michelle Gellis coming to do facial acupuncture. Mazen Al-Kafaji is going to be on campus starting in the fall to do his dermatology series. Michelle Gellis will be back in the fall to do facial acupuncture. So the CEU game is stepping up. So come on back. All right, let's get set up. Download your newest one. Look at my email, everyone. No, you can. The whole world is seeing it right now.
Oh,
It's okay. Come to me. There we go. Hi, everyone. So we'll listen to Carol, and then we'll go to lunch for an hour, and then we'll be back. Carol is another one of those people whose names keeps coming up. When's Carol going to be done with the doctoral program? Because we need her to teach. So I'm very excited for her to speak here, but also to have her, like, even in our profession. She has over 20 years of healthcare experience outside the acupuncture world. She's done research. She's worked in pharmaceutical research. She's worked in hospitals. We've both done time at Zhejiang Hospital in Zhejiang, China, which was really interesting. And she also spent time at the Touro University of Osteopathic Medicine. So please welcome Carol King. She's one of our current DAOM students. She's in reproductive medicine in the doctoral program and is finishing the program in April and working on her dissertation now. So this is kind of not an introduction, but like this is pieces of your dissertation swirling around in her brain, put onto a PowerPoint. So welcome.
Thank you so much. I'm so humbled to be here and to be amongst such distinguished and amazing colleagues and presenters that I respect and have learned from so much. And as Dr. Dow said yesterday, I'm a continuous student, always learning, and I'm just so grateful to be able to share some of what I have learned over the years with you. And just to kind of talk about my journey a little bit into this, I started on the Western side of the equation largely. I grew up with a father who was a physician, an MD physician, and was on all the meds and all of that from early on in life. And then I developed a series of problems in my 20s, which as I was in a medical school at the time, I was getting a lot of care from from my teachers and from other DOs and MDs. And my problems were not just persisting, sometimes getting worse. And so I turned to nutrition and I turned to an acupuncturist. And that's when everything changed and I got better, got off all meds. And so nutrition and food has become a big part of my passion. It's part of what I'm writing my capstone on. And I just want to share some things that I think are really important about food with you. With that, as a student and as this being kind of part of my capstone, I've written a large volume of material that I'm going to try to condense because I kind of promised formulas in the title. And because a lot of you are already very skilled with the Chinese medicine portion, I feel like I want to focus more on certain pieces from the food aspect of the equation, from more of the Western point of view or the bridged point of view, along with studies that you can take into your clinical practices. And then, the formulas you'll have on your slides. If we can get to it, great. I doubt it. But yeah, so here we go. And I'm going to kind of be reading because I'm so nervous. So, so food formulas and fertility is what we'll be talking about. Currently in 2023, the CDC states that 1 in 5 women, so 19% of women between ages 15 and 49 with no prior births, are unable to get pregnant after 1 year of trying. So this is up. This is going on an upward trend. We can compare this to 10 to 15% over the course of the last 20 years prior, showing that infertility is on the rise. When you consider, like Dr. Magarelli said, the #1 cause of mortality in the US is coronary artery disease, which is a largely diet-related condition, we need to look more closely at what it is that US citizens are getting wrong regarding health and nutrition. When you probe into this further, it becomes very clear that we have a crisis on our hands that goes well beyond poor nutrition, tipping over the first domino, leading into all kinds of conditions, including infertility. So what is it that we are missing in terms of health and nutrition in the US? Unfortunately, big agriculture profits from economically maximized food product, and big pharma profits from disease. So there's a meme that has always stuck with me about the pharmaceutical industry, which is every patient cured is a customer lost. When we combine profits with healthcare outcomes, we are looking at a much different kind of picture that takes health out of healthcare. So we have to keep this in mind. We have to keep this in the back of our heads as acupuncturists, because we become really important diet and lifestyle teachers to our patients. So how does this tie into infertility? From a Western medical point of view, infertility is diagnosed when a couple fails to conceive after 12 months of regular intercourse. At this point, testing is recommended to investigate basic fertility measures, including reproductive hormone tests, ultrasound scans, semen analysis, and others. From the Western perspective, you can see, causes would be ovulation disorders, uterine and cervical abnormalities, fallopian tube damage, so on and so on. We always have to remember that the partner is part of that equation too. So, don't always look at the female side of that equation, or the woman, or the one with the womb. But these diagnoses are actually branches of the organism. When we get to the root of many of these issues, we can often find a lifetime of poor dietary and lifestyle factors that led to these blockages. From an Eastern point of view, the main patterns that we see that come up are kidney yang and kidney yin deficiency, so both deficiency patterns, and then from excess patterns, we see liver qi stagnation, phlegm damp stagnation, and blood stasis. Risk factors that lead to these patterns are constitutional weakness, overwork, excessive physical work, sexual activity at too early of an age, invasion of cold, irregular diet, exposure to toxins, and dental issues. So from a TCM perspective, the kidney stores the Jing and governs reproduction and is the foundation of fertility. It partners with the liver and spleen, which are all Legian meridians that support the fertility in concert. And these all go to the genitalia, as we know. The spleen is key to protecting the Jing from rapid consumption. So this is the postnatal part of the equation, which is maintained by the spleen. If the spleen is deficient, then digestion and absorption of nutrients are impaired, and the body struggles to support itself first and foremost, as it is not well equipped to support a new life growing within the organism that is out of balance. So if we look at this from a 5-element perspective, the spleen's stomach is the earth, which requires healthy soil in order to grow new and vital life. In the same way, in a human organism, the earth needs healthy intestinal mucosal integrity, needs microvilli function, good bacteria, and optimal pH balance for proper digestion and nutrient assimilation. We must remember also that the alimentary canal is part of the gut and it begins with the mouth. So as we all recognize, the tongue is an important diagnostic tool for gut health, but we may not also include teeth in this equation. A study published in the Journal of the American Dental Association showed that women with periodontitis are 4 to 7 times more likely to deliver prematurely and also have an increased risk of miscarriage. On average, women with periodontal disease took 2 months longer to conceive. So they concluded that gum disease significantly increases the risk of preterm and low birth weight. So this is something to keep in mind because we look at our patients' tongues, and so we're kind of already seeing what's going on in the mouth. If you see some, the teeth don't have great quality or good integrity, just ask them, how's your dental hygiene? Have you been to a dentist lately? Because that could help them with their trying to conceive efforts. In this talk, we'll examine fertility from the point of view of Earth as the central axis. There are many causes that can lead to infertility, but we will discuss how we can best support the spleen-stomach system, which may have a downstream effect in increasing fertility and carrying a baby to term. But before we look at what we should be doing, let's take a closer look at the foods that contribute to an inflammatory response and should generally be avoided for women having difficulty trying to conceive. So foods to avoid would be sugar, trans or partially hydrogenated saturated fatty acids. And this is foods to be avoided in general. So we'll go into fats in a bit, but also processed foods, chemically derived foods, food additives, glyphosate, and genetically modified organisms. Gluten and dairy have an asterisk because they're okay in moderation with a generally healthy body. But if there's an inflammatory or autoimmune condition, like hypothyroidism, PCOS, endometriosis, or celiac disease, these are best to be avoided altogether. Alcohol, as we know, is teratogenic, best to be avoided altogether. Caffeine, this is something that a lot of people ask questions about, so I'm going to give you a study. There's a Yale study that had an N of 1909 women, married women, and it showed that women who drank over 300 milligrams of caffeine per day have a 27% lower chance of conceiving for each cycle. Those who drank less than 300 milligrams a day had a 10% reduction in cycle compared to women who had no caffeine at all. And just for reference, what's 300 milligrams? So one Starbucks tall coffee, which is a small, is 260 milligrams of caffeine. A double cappuccino is 150 milligrams of caffeine. A cup of black tea is 50 milligrams, and 1 cup of green tea is 25 milligrams. So if they have to, go with the green tea, which also has catechins, or ECGC, which helps to protect against cancer. But it's generally best to avoid these altogether, just, giving general guidelines. So when we look at, and I want to spend some time on this one because I think this is where we really run into problems. Macronutrients. So when it comes to the diet, we need to be able to navigate between health versus toxicity. So this can be a difficult field to navigate in our society because we often let our emotions commandeer the chariot, and we find ourselves easily indulging in toxic or inflammation-causing foods. It's very easy to be in celebration with friends, having a pizza, beer, cookies all in one sitting, but this can contribute to an inflammatory cascade within the body. So for our patients that are seeking increased fertility, it's important that we help educate them about their choices and how their choices will affect their outcomes. In the following slides, I'll remind you of some basic aspects of macronutrients and provide you with some study data that may help you with your persuasion of some of your patients. When we require macronutrients in order to survive, and this is a general recommendation of how much we should be getting in our diet. So proteins 10 to 35%, carbohydrates 20 to 35%, and fats 10 to 35% of our daily calories. There are good and bad versions of all three of these categories. So this is what we're about to go over, starting with a basic understanding of what they are and then how to optimize them and use some study data that show effects of what happens when you get too little or too much in relation to fertility. I just want to mention a great study called the Nurses' Health Study, which Harvard School of Public Health took data from 121,700 nurses that were trying to get pregnant and reported on biennial surveys over the course of 8 years in the first leg of the study. There were 3 legs of the study. What's really great about this study is that the data that was gathered from a very large sample size of nurses, and they used nurses in particular because of their knowledge of medical terminology and their astute ability to answer the survey questions. So this study provides a great deal of data regarding diet and fertility. So I'll be referencing this quite a bit. So looking at protein, just to remind you all, 3 amino acids make up 1 protein. There are 21 amino acids that we require for life. Of these 21, 9 are considered essential, meaning that we cannot synthesize them from within our bodies. We must get these essential amino acids from our diet. Protein provides the structure for most of the tissues, skin, and hair, as well as biologically active molecules in the body. The enzymes that break down your foods, the hemoglobin that delivers oxygen to your tissues, the immunoglobulins that protect your immune system, these are all proteins. Proteins account for about 75% of the weight of your body when you remove all of the water. So providing your body with the right building blocks is crucial. The basic amount of protein needed for a sedentary lifestyle is 7 grams per 20 pounds of body weight. This is sedentary, not for Dr. Credenda, who eats a crazy amount and runs ultra marathons. But so for a 140-pound person, you'd need to eat 50 grams of protein per day. Does the protein source matter? The answer is yes. The protein in animal products, such as beef, fish, and dairy, is complete, meaning it contains all the amino acids that your body needs. Proteins from beans, grains, vegetables are often incomplete, meaning they lack 1 or more essential amino acid. So combination of incomplete proteins within the same meal or over the course of the day can provide one with all the essential amino acids that are necessary for life, which is why a lot of people can live as a vegan. Some classic food pairs would be rice and beans, peanut butter and whole wheat bread, or tofu and brown rice. Falling short of basic protein requirements can stunt growth in children, shrink muscle tissue, weaken the immune system, damage the heart and lungs, and impair overall longevity. In extreme conditions, one can develop kwashiorkor, which causes edema in the tissues. We don't really see this in the US. This is like the ads from the 80s of the kids in Ethiopia with the giant bellies. That was usually from that malnutrition and not having enough protein. In the Nurses' Health Study, participants were grouped by their daily average protein intake, where the lowest group was getting 77 grams per day, while the highest group was getting 115 grams per day. Women in the highest protein group were 41% more likely to have reported problems with ovulatory infertility than women in the lowest protein group. What's more is when you look at the type of protein, another distinction occurred. When the total calories were kept constant, when you swapped 25 grams of animal protein for 25 grams of carbohydrates, there was an increased risk of ovulatory infertility by 20%. Swapping 25 milligrams of plant protein for 25 milligrams of grams of carbohydrate reduces the risk of ovulatory infertility by 43%. So interesting to see the difference between animal and plant protein. And then when you compare the two directly, swapping 25 grams of animal protein for 25 grams of plant protein reduced the risk of ovulatory infertility by 50%. Incidentally, so it's important when you're getting your proteins and when you're telling your patients to eat more protein, include plant protein in that recommendation. So that's basically, it's not to say don't eat red meat or anything like that, but get variety. Variety is key. I did want to mention this because we're in LA and intermittent fasting is a thing. Incidentally, a newer study came out in Japan in 2021 that looked at the influence of time of day of protein intake in mice and humans. When more protein was consumed earlier in the day at breakfast, muscle hypertrophy was influenced. Higher muscle functions were observed in subjects who ate dietary proteins mainly at breakfast than at dinner. So this should be kept in mind when patients ask about intermittent fasting. It's much better for physiological function to follow an early eating schedule, starting early in the morning and ending mid-afternoon, than for those who eat later in the day from 2 to 10 p.m., for example. And this also falls in line with the TCM meridian clock. 3 of the main organs of the digestive system begin early in the morning. The large intestine is from 5 to 7 a.m., stomach from 7 to 9, and spleen from 9 to 11 a.m. So we're meant to break our fasts during these times. The best sources of protein for fertility, I'm just going to kind of let you read that and move on because I've got quite a bit of slides. All right, so carbohydrates. They're composed of 1 carbon, 2 hydrogen, and 1 oxygen bound together as a saccharide. And these are divided into 4 different groups: monosaccharides, disaccharides, oligosaccharides, and polysaccharides, which are also known as sugar, starch, and cellulose. Oligosaccharides are longer chain glucose molecules with 10 or more that take time to break down and are gut protective as they're a component of fiber from plant tissue. These are keys to microbiome health. Fructooligosaccharides are found in Jerusalem artichokes, asparagus, burdock, chicory, leeks, and onions. Galacto-oligosaccharides are found in human milk and function to develop the gut flora in infants, and now people are taking them as supplements to help to rebuild their microbiome right now. Cellulose is an important polysaccharide in the cell walls of plants that provide us with insoluble fiber, which act as binding agents and help to bulk up the stool and maintain a healthy GI tract. One of the most important components of carbohydrates that we consume far too little of is fiber. Adequate dietary fiber is associated with digestive health, and it reduces the risk of heart disease, stroke, hypertension, certain GI disorders, obesity, type 2 diabetes, and certain cancers. Only 5% of the population meets the suggested fiber recommendations. According to a 2009 national survey data, mean daily fiber intake was only 16.2 grams, where the recommended amount for a woman between 19 and 50 years old should be 25 grams. So they're falling short by 9 grams. Mono and disaccharides are sugars, which are what most people associate with carbs. Refined sugars are long chains of glucose molecules joined end to end. And when digested, it'll trigger a rapid rise in blood glucose, which then causes the pancreas to release a huge amount of insulin, which we've learned plenty of from Dr. Magarelli this morning. Ideally, insulin acts as a key in muscle cells to usher glucose molecules in for energy storage. When there is an abundance of glucose and insulin, glucose gets stored in fat cells. Over time, the body can become resistant to insulin, which we discussed what happens with polycystic ovarian syndrome and other issues with too much insulin and insulin resistance. Refined sugars are where we fall into issues of excesses that result in diseases that down the line can result in infertility. It becomes disruptive to hormones that regulate the reproductive system and can be problematic for fertility and normal ovulation. Refined sugars are what we find that are derived from sugar cane, sugar beets, corn. We find these in candy, breakfast cereals, soda, juice, baking mixes, condiments, some bread products, many baked goods, high fructose corn syrup, so on and so on. In the 1940s, US citizens ate 40 pounds of sugar per year, By 2005, that number more than doubled to 100 pounds of sugar per year per person. One study looked at a woman with increased advanced glycation end products, where proteins or fats become glycated as a result of exposure to sugars, which indicates the effects of insulin resistance. Women with increased AGEPs had fewer eggs retrieved and fertilized, as well as fewer good quality embryos. They found a 23% pregnancy rate in women with normal blood sugar versus 3.4% in women with high levels of blood sugar. Increased blood sugar and insulin impair mitochondrial function, which decreases ATP levels. In the same study on mice, eggs from diabetic mice were more likely to have an incorrect number of chromosomes. Women undergoing IVF with increased sugar or insulin also had an increased risk of impaired embryo development, implantation failure, and risk of miscarriage. So it's really important that we monitor blood sugar in our patients, especially when they're having trouble trying to conceive. We talked about the first study there, just a few more studies. In Denmark in 1999, 165 couples trying to conceive. They measured the average hemoglobin A1C over 3 to 4 months. Those with normal to high A1C were half as likely to get pregnant over 6 months compared to those with low to normal A1C. So it concludes that an increase in blood sugar compromises fertility. In the second round of the Nurses' Health Study, in a sample of over 100,000 women, while total carbs were not connected to ovulatory infertility, the type of carbs were important. They found that the quickly digested carbohydrates that increase blood sugar, 78% were more likely to have infertility than with the people that had a predominantly slow to digest carbohydrate rich diet. And lastly, an IVF study, small study, took 12 young healthy women with previously failed IVF cycles, just one IVF cycle, and they had them reduce their carbohydrate intake from 49 to 40% and increase their protein intake from 15 to 27% for 2 months before the next IVF cycle. And what they found is that in the normal diet, 19% of those eggs became blastocysts, whereas 2 months with the diet prior to transfer, 45% of the eggs became blastocysts and 10 to 12 of them became pregnant. So what carbs should we eat? Whole unrefined grains take longer to break down because starches are wrapped up in grain or seeds, so glucose is released gradually over time, and carbs are digested more slowly, and there's no sudden spike in glucose or insulin. And it's best to prepare these properly by soaking and or sprouting. If it's not prepared properly, then it can increase phytic acid, which prevents the intestines from absorbing and assimilating nutrients and contributing to inflammation. Almost all vegetables are superfoods for fertility. It's best to get a wide variety of color, which will give a good dose of polyphenols, which are great antioxidants, protecting against oxidative stress. You can see which ones are not great to have in large quantities. Whole fruit contains sugar, but it's okay in moderation. Sugar and fruit combined with fiber will slow the absorption so that there's no glucose spike. It also contains beneficial antioxidants and vitamins to boost fertility. Ideally, you want to do 2 servings per day, but in inflammatory conditions like PCOS, limit to 1 serving per day. And it's okay to do a small amount of dark chocolate, of the 72% dark chocolate or above. This can actually be beneficial because of phenylethylamine, which is a slight antidepressant and stimulant similar to adrenaline, causing a sense of happiness, which helps to reduce stress. It has antioxidants that protect against LDL oxidation and may lower blood pressure and minimize clotting factors. According to Dr. Dow, it's okay to have 1 ounce of dark chocolate 3 times per week. And then again, foods that you should avoid: simple sugars, bleached flours, GMOs, and glyphosate. Just one word on glyphosate. Does everyone know what that is? Okay. So in 2015, glyphosate is not the best for $35 you ever spent. It's the worst by far. So in 2015, after a review by the World Health Organization's Cancer Research Arm, they concluded that glyphosate is probably carcinogenic to humans. And so glyphosate is the main ingredient in Roundup, the Monsanto product that is sprayed on all of our crops, especially the GMO crops. In 1974, glyphosate was introduced and sprayed on crops as a pesticide. And then in 1996, they developed Roundup Ready, a GMO product that was genetically engineered to be herbicide tolerant that resulted in a 15-fold increase in glyphosate spraying globally. So 2/3 of the total amount of glyphosate applied on US soil was sprayed between 2004 to 2014. Roundup Ready crops, these are GMO, genetically modified organism crops, include soy, corn, canola, alfalfa, cotton, and sorghum, and currently wheat is under development. A study in interdisciplinary toxicology in 2013 concluded that reproductive issues associated with celiac disease, such as infertility, miscarriages, and birth defects, have been associated with glyphosate. So this is something just to keep in mind, make sure that your produce is organic and free of pesticides. It's really important. So fats. Fats serve as both energy sources and energy stores. They are sources of essential fatty acids, which are not synthesized in the body. So, like with the essential amino acids, essential means that we need to get this from our diet. Our body doesn't produce them naturally. So fats also provide us with cholesterol, which, as you know, is a necessary building block of all the sex hormones, testosterone, progesterone, and all the estrogens. So we need fats. We need them to absorb other fat-soluble vitamins like vitamin A, D, E, and K. We also need fats to maintain healthy skin and hair. They insulate the body against shock, maintains body temperature, promotes healthy cell function. It also serves as a storage site for toxins until they can be metabolized or removed from the body by excretion, urination, bloodletting, sebum excretion, and hair growth. It's important to differentiate, like with the others, between the different types of fats. So you've got your saturated fats versus your unsaturated fats. Saturated fats are found in beef and dairy products made with whole or reduced fat milk like yogurt, ice cream, butter, cheese. There's also palm oil, coconut oil, and partially hydrogenated oil, which are all higher in saturated fat content. Generally, it's considered a risk factor in increasing triglycerides and LDL, which is the bad cholesterol, and lower levels of HDL, which is the good cholesterol. These are all considered to be risks for cardiovascular disease. But this is a simplistic way of looking at saturated fats and their effects on cholesterol, which doesn't take into account thrombogenicity, insulin resistance, LDL-HDL ratios, or the fact that coconut oil also contains lauric acid, which raises HDL levels, the good cholesterol, and can lower overall risk of heart disease. So there's a bigger story to saturated fats, but generally, we tend to think of saturated fats as a risk factor for higher cholesterol. With unsaturated fats, you've got the monounsaturated fats and polyunsaturated fats. Monounsaturated fats are found in animal flesh, like red meat, whole milk products, as well as nuts and high-fat fruits like olives and avocados. Olive oil is 95% monounsaturated fat, and it's high in oleic acid, which are found to lower the incidence of insulin resistance. Polyunsaturated fats include two essential fatty acids, alpha-linoleic acid, which is known as omega-3, and linoleic acid, which is known as omega-6. A third essential fatty acid that the body does not have, the third essential fatty acid is also arachidonic acid, which is associated with the inflammation cascade, and bodies already tend to have this in excess. Essential fatty acids can be viewed in terms of their effect on blood clotting. Omega-6s and arachidonic acid encourage clot formation, whereas omega-3s reduce clotting. So omega-3s help to promote healthy, youthful skin and hair, support thyroid and adrenal activity, bolster immunity, normal growth and energy, healthy blood, nerves, and arteries, and are crucial in the transport and breakdown of cholesterol. A deficiency of omega-3s will result in skin disorders, eczema, dry skin, dry hair, loss of hair, nail problems, gallstones, irritability, liver problems, varicose veins, and susceptibility to infections, low body weight, retarded growth, and infertility. The types of omega-3s are ALA, which is found in plants like walnuts, seeds, flaxseed, and hemp seed. And then you've got DHA and EPA, which are found in algae and fish. DHA is the one that we all know of that we want to make sure that our patients take, especially during pregnancy, because it helps for brain development in fetuses. Omega-6s should ideally be in a 2-to-1 or even a 4-to-1 ratio with omega-3 for the best protective effects when it comes to the body. What's problematic is when we get too much omega-6 to omega-3 ratio, and that becomes inflammatory to the body. We typically get in the standard American diet about a 20 or 30-to-1 ratio of omega-6 to omega-3. So we tend to want to try to avoid omega-6s as much as possible. A good component of omega-6 is GLA, gamma linoleic acid, which reduces inflammation and is found in nuts and leafy green vegetables. But in general, oils that are high in omega-6s are sunflower, safflower, soy, sesame, corn, vegetable, and grapeseed. And it's just important to remember this because a lot of people don't realize, they'll tell you like, oh no, I only eat olive oil. And they don't really realize like, oh, that bag of chips that you just ate has safflower and sunflower oil in it. That hummus that you just ate has safflower and sunflower in it. So you find those oils because they're really cheap and they're good preservatives in a lot of the packaged processed foods. Bless you. So some studies on fats and fertility. In the Nurses' Health study, with dairy, there was an increase in full-fat dairy was associated with a decreased risk of ovulation disorder. So women with increased full-fat dairy intake had increases in chances of live birth. So that's a good thing that a lot of people would like to know. 2017 Harvard study on IVF, women with higher omega-3 had higher quality embryos and were more likely to become pregnant. Also, women with above average omega-3 fats in the blood have an increased chance of conceiving through IVF. And in 2018, 500 couples trying to conceive, 92% that were eating seafood 2 times a week or more were pregnant at the end of the year, compared to 79% of couples who ate less than that. So what are the most helpful fats? Again, I'll let you just read through that. Generally, there's, like fish is a great source, olive oil is a great source. And then, as we saw, like full fat dairy, maybe why not, unless you have an autoimmune or inflammatory disease. Having a clear understanding of how to balance our macronutrients and how to optimize them for increased fertility will best help us help our patients in their fertility journey. And in this, balance is key. So making sure that they're getting the right amount of protein from plants and fish with a small portion of red meat and full-fat dairy is ideal. Emphasize the importance of cutting out simple refined sugar altogether and opt for whole grains, complex carbohydrates that are rich in poly and oligosaccharides. And also educate them on fat and the nuance of making the right choices of fats and choosing fats that will provide protection and will benefit them in their fertility journey. So those are macronutrients. Let's also look at micronutrients. Micronutrients are vitamins and minerals that the body requires for basic important functions. The main groups of micronutrients are water-soluble vitamins, fat-soluble vitamins, macro minerals, trace minerals, and then you've got your phytonutrients, which are also known as phytochemicals or polyphenols. These ones are things that you'll find in colorful plants. So for example, like the orange color of carrots are rich in beta carotene, and you'll find that in other orange produce as well, or the green in vegetables that makes chlorophyll. These are all phytonutrients, so that are really great and act as antioxidants for our body. If they're not really able to get a wide variety in their diet, then it would be a good idea to have them go on supplements. Ideally, we want them to, go to the farmer's market, get a community supported agriculture box delivered to their home, which include meats and, farm raised organic eggs and all of that, but not going to happen with a lot of our patients. So generalized guidelines would be to tell them, when you go to the grocery store, try to shop in the periphery. That's where most of the living, healthy foods are. Stay away from the middle aisles where the canned and processed foods are. And then take supplements. And so these are basic supplements that kind of will ensure that most of their bases are covered. So this is where we'll kind of breeze through. So we just looked at how the spleen and stomach earth system can provide the post-heaven nourishment for the body and the ways that we can tailor our diets to either take us in or out of balance. But now we can look at root causes of infertility that may lay underneath the earth, and how we can use formulas in various foods, very specific foods that will help treat them in conjunction with the appropriate diet. And so I'm not going to read through all of the herbs that are in here. You can read these for yourselves, but just generally, you've got kidney yang deficiency, where if the Mingmen fire is insufficient, the uterus will be too cold to support a pregnancy. This can be due to congenital origin, or it can be acquired through miscarriages or terminations, excessive sexual activity, long-term illness, or severe yin depletion that affects the yang. Alternately, overconsumption of cold and raw foods can damage the kidney and spleen yang, which can lead to internal cold and yang deficiency. And a great formula here is Yogui Wan. Here are the herbs, and here are some great modifications for that formula, as well as some foods that you can focus on, as well as preparation of how to increase kidney yang in your foods. Then we've got kidney yin deficiency. This pattern may be congenital or acquired due to consistent stress and overwork. Could be due to excessive blood loss in menstruation or childbirth, multiparity, multiple abortions, or the repeated use of assisted reproductive therapy drugs, which all exhaust the yin. So alternatively, with internal heat, whether generated by emotional stress or overconsumption of alcohol or spicy and greasy food, will eventually consume blood and yin. So consequently, the Chang and Ren may have insufficient resources to nourish the uterus, which is unable to support a new life. So in a cascade effect, yin deficiency can compromise the growth of kidney yang. So we want to give them Zogui Wan. Here are some modifications for that, and some foods that can help boost kidney yang. Liver qi stagnation can arise from deficiency or excess. Deficiency of liver blood can hinder the free and smooth movement of liver qi, resulting in stagnation. Alternatively, any prolonged or intense emotions, especially stress and frustration, will in fact impact the liver function of governing the smooth flow of qi. Qi stagnation can transform into heat, which further disturbs the menstrual cycle, and it can block ovulation by hindering the transformation of yin to yang. Qi stagnation can also obstruct the free flow of blood and cause blood stasis. Blood stasis can then block the Chang and Renmai, causing dysmenorrhea and impairing your fertility. So Kai Yu Zhangtang or Xiao Yao San can be used for liver Qi stagnation with the following modifications and foods as well. And then phlegm damp stagnation, if spleen Qi is deficient, it can fail to transform body fluids, resulting in the accumulation of dampness and or phlegm. Alternatively, overconsumption of sweet, greasy foods can lead to phlegm damp and may manifest as obesity. This phlegm damp can block the Chang and Renmai, leading to ovulation and amenorrhea. Prolonged retention of phlegm damp can generate resulting in damp heat or phlegm heat, which can result in obstructions to organs related to infertility or to fertility. Qigong Wan would be a good formula to use with these modifications and these foods. And lastly, blood stasis is a secondary cause of the disease, secondary cause since it develops from other patterns. Typically liver Qi stag results in this. It can also arise as a result of residual blood left after an incomplete period, surgery, trauma, or childbirth, or from external pathogens invading the uterus. Blood stasis blocks the extraordinary vessels so that the uterus and uterine collaterals are closed to the possibility of conception. So Xiao Fu Ju Yu Tong is the formula for this. And here are the modifications, foods to eat. Lastly, there's the 28-day cycle, which we use a lot in Chinese medicine, which I'm sure a lot of you are already familiar with. These are like the different seasons of the year. So phase 1 would be winter. This is the season of cleansing, contracting and ending. This is when storms arrive and the harshness of winter inhibits the activities of many living things. Plants shed remaining leaves, animals hibernate, and the land is frozen. And so with menstruation, the uterine lining sheds, contracting and cleaning of the uterus. The female hormonal activity is dormant and mirrors the quietude of winter. And the follicles are waiting to grow like seeds planted in the soil. So during this time, we want to invigorate, move blood and Qi. If the period is heavy, you invigorate blood and stop bleeding. Phase 2, day 7 to 14, this is as the follicle begins to grow. This is spring. This is when plants begin to sprout. Earth is filled with new life and hope and beginnings. This is the time when menstruation and ovulation starts a new fertility cycle. The follicles gradually grow until one follicle stands out to present the egg and holds the potential of becoming a new life. During this time, we want to nourish the blood because it's empty and tonify the kidney. Phase 3 is ovulation. This is the summer phase. This is when life is in full bloom, reaching its most abundant level of energy. The follicle grows to maximum size and maturity before releasing the egg. LH, FSH, and estrogen work in concert to both release the egg from the follicle and also nourish the uterine lining to protect, to build up and secrete mucus, to moisten and make itself attractive, to provide a receptive palace for the embryo. So during this time, you want to tonify the kidney and spleen, and if necessary, resolve damp. Lastly, phase 4, the luteal phase. If there has been no embryo implantation, we move into autumn. The earth continues to be filled with activities. Leaves begin to fall, temperature drops as the land prepares for winter. The wind is stronger, the air turns drier. This is the season of harshness, when earth readies for the final shedding of its leaves and branches. The uterine lining continues to build up before its final shedding. This is also the PMS phase. So during this time, we move Qi, invigorate blood, warm the uterus, and expel cold and resolve damp phlegm. Here's a list of foods that I would encourage you to look over and maybe create some version of your own to give to your patients. It's a great thing to have something to have your patients take home so that they can ponder and utilize for themselves. Some general do's and don'ts, and some just general last words. I think it's important that we identify the root causes. Look at the diet and have your patient maybe do a food journal and or ask them what they ate in the last 24 hours. They'll inevitably tell you that they never eat this way. And in reality, their ideal selves is what they want to present to you, but the actuality of what they ate before seeing you gives a real snapshot of what they really truly do. Also, don't just take your patient's word for it when they tell you that they eat healthy. Define what healthy means. What specific foods do they eat on a regular basis? Ask them about where they get their vegetables from and which ones are they eating. Are they fresh, frozen, come from a can? Are they drenched in sauce? Also remember that salad is a poor excuse for vegetable eating. You need a lot more variety than that. And also vegan is not the same as healthy. Remember that nearly all carbs fall into the vegan category, which means that a diet full of vegan donuts, Skittles, French fries, and Gatorade all fall under the category of vegan. As their healthcare advocate, hold them accountable and be a champion for them in making strides in their diet. Chances are they already have enablers of bad food habits all around their lives. So it takes a lot of effort to turn down a cake at a birthday party or a glass of champagne at a celebration. So we need to be the enabler of their health and cheer them on when they make positive changes in creating newer, healthier habits. Every time they make the right choice, it's a victory. So be the one who celebrates with them. And treat accordingly and phasically. Keep your patients attuned to their cycles and how to best support their bodies as their bodies shift. You don't treat a plant the same way in the winter as you do in the summer. The plant has different water, soil, and pH requirements during different seasons in order to bear the most fruit. Keep that in mind with your patients and their diets. And then give them a list of the foods to avoid as well as the foods to eat. And if they have an inflammatory or autoimmune condition, really stress the importance of the elimination of gluten and dairy and or the AIP diet, autoimmune protocol diet. And then have them pay attention to their calories and how their macronutrients are distributed. Use herbal formulas to boost the power of your fertility treatments and keep them on basic supplements to support their uterine integrity and their pregnancy. And as Hippocrates said, let food be thy medicine and let medicine be thy food. Thank you so much. And then there's references to the studies that I mentioned in the last slides.
It's okay. Another 5-hour class in a 40-minute lecture.
Yeah.
Good job.
I cut that down from really so much more.
That was awesome. Good job.
Thank you.
Questions, thoughts? I knew that was.
Excellent. I'm very proud of you, my dear. Good job. There is a paradigm shift in the understanding of saturated fats.
Yes.
And if you can comment on that, let's just keep it at that. What is the paradigm shift that you understand about saturated fats?
So there is more to the increase in cholesterol than just saturated fat content as a contributing factor. And so I think maybe the paradigm shift that you're talking about is there's more of a look to like, how does sugar play a role in that?
Yeah, I think the bottom line is the data that created the scare about eggs and egg yolks and created the scare about meats and saturated fats and butters as being a pathology turned out to be erroneous. The data was manipulated, unfortunately.
Yeah.
So I am not suggesting just fats, but I'm suggesting that we may, you actually said it, it's the combination of the sugars with mostly trans fats that created the problem rather than the consumption of, let's say, grass-fed meats or like you said, cage-free eggs, those kind of things.
And there was actually a study that showed in France, I believe, that showed that consumption of egg yolk reduced cholesterol levels.
It's called the French paradox. The original author threw that data out when they were looking at the world because it absolutely didn't meet his model, his thesis.
Right.
And that's criminal as far as I'm concerned.
Agree.
I just want to say that gummy bears and Swedish fish are immune from any of these discussions. Questions. And vanilla
And they are
milkshakes.
vegan, true.
No, gummy bears are.
Oh, do they have gelatin,
Yeah,
maybe?
they have gelatin.
Oh,
Swedish
not
fish are
vegan.
Hi, thank you so much. That was such a great lecture. I'm just wondering if you can ever have too high of HDL, like if having too high of a number takes it out of like a healthy range.
I haven't heard of too high of an HDL. Dr. Mag is shaking his head no.
Absolutely not.
Um,
Absolutely not. Who asked the question? Okay, the way I think of HDLs are like you see in that commercial, they'll actually, the higher the HDL, the more likely that your cardiovascular system will be scrubbed of the atherosclerotic plaques. So it actually acts the exact opposite of what the very low VLDL and LDL. Now, so I could just make one point. Sometimes, Sometimes as you shift to an actual better diet, you'll see a transient elevation in LDLs. That is not a bad thing. It's taking the very low density, which are the worst, transitioning them to high density, which are the better. So there's you can sometimes get concerned that your labs look like, in a sense, worse. Just look at the HDLs, just look at the VLDLs, and consider the LDL as a transition. It's a train moving either way. But no, the LDLs are the scrubbing bubbles of the cardio HDLs. The HDLs are the scrubbing bubbles of the for the vascular system. So too high is not a bad thing.
2 questions, sort of related or not. No. So I didn't look through your references. Do you have favorite books on nutrition? People are asking for more than just besides Healing with Whole Foods. Do you have other books that you turn to?
I was using a lot of studies, specific studies with nutrition. I did have Healing with Whole Foods, and then the Tao of Nutrition. And then some of these books are related to fertility, like Dr. Mao's Secrets of Fertility. Yes, actually I have a lot of books on nutrition.
Awesome.
The Fertility Diet. Dr. Ehrlich, who spoke yesterday, has a great book. And then there's a book actually on the nurse's study itself. But yes, the answer is yes,
so
they're in there.
They're in the references. And then somebody asked, somebody mentioned that they asked their patients to food journal, but I wanted to mention that you actually do a cleanse with your patients, and it's open to the whole world. But do you have them journal and look at these things while they're doing it, or is it specifically a protocol?
I've been putting my patients on a 21-day cleanse since 2020, and I used to offer it 4 times a year. Now I just offer it once a year. And it's a 21-day purification program, and it's like a whole intensive thing where it's like not just eating a certain diet and taking supplements, but it's also like thinking about what it is that you're eating. So there's meditations, and there's the journaling, and there's also just being really cognizant of what's going on with the food choice process. And like, so it's a journey that we go on together. And also with a lot of my patients, I do send them home with a 1-week journal. It's just like a page that I get from Standard Process. But you could have one made, and it's just, they fill them out with the water intake. They also put in their sleep, as well as their bowel movements and stuff like that, so that I can get a real sense of what's going on. And then I grade it afterwards. I'll highlight the good and the bad.
Nice. Last question. It's actually like maybe 2 questions or 3 questions combined, but there's questions around the difference in fat profile from standard versus grass-fed, but then also eating nutrient-dense organ meats versus organic grass-fed. So like, in your research or in your offerings to your patients, do you discuss those kinds of things? Do you recommend organ meats?
Yes. Yeah, absolutely. And yeah, that's part of, I cut that out for time. But yeah, the quality of the meat that you get is very important. It's important that you're, that you that you eat as much of the rest of the animal as possible. Definitely like beef liver and chicken liver and cod liver for that matter are great for fertility. And then it's important to avoid the ones that have hormones and antibiotics. So most of your conventional meats are going to have that. And you want to make sure that you're getting the ones that are really rich with nutrients and vibrancy in life. There's also like this component that we don't talk about, which is the chi of the animal, you know, and like the state of the animal. I've had some of my sensitive patients tell me that after eating bad quality meat, they'll have nightmares of being tortured. And you know, and it'll happen every time they make those choices to eat those kinds of meats. So there's this whole other component that we don't even really talk about that much in mainstream, but yeah, so I don't know if that really answers that question.
Yeah,
but
totally does. And then last question. There's been a lot of information. Consumer Reports just announced high levels of lead and cadmium contamination in most dark chocolate. So are you telling your patients to avoid chocolate and dark chocolate during fertility?
Right.
I haven't looked at the study, so I can't.
I just started looking at, yeah, that's a good.
That was my question too. I actually have kind of started diving into the whole chocolate thing, and the cadmium and the lead levels are so high in the darker the chocolate, the more the ingredients of cadmium and lead are like 174% greater than the daily requirement or daily acceptable level, which is should be nothing really, but they're really high. So what they're recommending in the studies were done in California in December of 2022, it was released. They said that 70% dark chocolate was probably the one that you could have occasionally. Mm-hmm. So I have changed because I used to let my patients have dark chocolate as well as a treat. And now I've reverted to 70% is the highest dark chocolate they can have, and very much as a treat because of it.
Yeah, and I did notice that it's like a lot of the brands that you would think that would be okay, like the Alter Eco and the it's in the soil. Yeah, exactly. Yeah. Yeah, the amount. Yeah.
Were they using the California standard for the measurement? Because California is like 0.5 parts per million, and that's going to give you the elevated, that like Germany's 10 parts per million and Japan's like 5 parts per million. So the California standard is based on Prop 65, and not to get political, but that's one of the worst pieces of legislation ever written. So yeah, always striving for less lead, but I would tend to use kind of EU standards in that. It's still probably elevated, but I would that's what I'm going to go back and look this afternoon. So that's my research for the afternoon.
And just to add, I work with a toxicologist and had these very particular questions for him. A proper functioning liver and excretory system will help with eliminating the heavy metals, because they are everywhere. It's in the periodic table. We can't avoid them ever. And you know, these places that do have like volcanic soil will have the higher cadmium. Now, I happen to think that rich soil is actually, you know, provides the trace minerals. It's all a balance. It's all a balance. But what's also really important is the quality of chocolate. The higher the tannins, the more that the more binding happens and the excretion of excess heavy metals. So it's all a balance.
Mm-hmm. Good point.
One more question, and then we'll have lunch.
Thank you, that was very good. I couldn't help but laugh because when we ask our patients like what they're eating, you know, so sometimes if I feel like they're like, I'll say, what'd you have for breakfast, blah, blah, blah. If I feel like their eyes are kind of going like this, like, oh, right, I don't want to tell her. I say, what do you have in your refrigerator right now? Can you tell me what's in your refrigerator right now? And you can just see them going, oh, I'm busted.
Thank you.
Thank
You,
you.
Carol. Thank you, everyone. Let's eat. Let's nap. Let's drink water, stretch, do everything, and we'll see you in 1 hour. Thank you, everyone.
You said it's an hour? An hour. An hour. Okay. No problem.